Good afternoon, everyone. I am Dr. Rujul. I'm Dr. Rujul Javeri, obstetrician gynecologist at SRCC Children's Hospital. I welcome all of you for this masterclass. Today's masterclass is on general pediatrics, and we'll be starting with our first speaker, that is Dr. Shashank Parekhji. Sir is a senior consultant pediatrics in pediatrics and neonatology and consultant pediatric nephrologist at Bijaywadia Hospital. Sir is going to be speaking about interpretation of urine analysis report and its further management. I welcome sir on behalf of all of us.
Thank you, Dr. Rujul, and good afternoon, everybody. Hi, I'm Dr. Shashank Parekhji. I'm going to talk on interpretation of urine analysis report and a little bit on the management part of what we see. Now, this is one of the very commonly done tests. It is like a window to the kidneys, where it gives you an idea as to what is actually happening inside the kidney just by seeing a urine report. It is not a diagnostic test of any particular illness because there are multiple things that come positive or negative in the urine parameters in multiple illnesses of the kidneys, which could be either localized kidney or it could be part of a systemic illness. But it gives you an insight or idea what or where we are dealing with. So it is not a primary parameter of renal function, but it is a required tool for confirmation of renal disease and an insight to what kind of a renal disease we may be dealing with. The advantage is it is available at the smallest of places, smallest of villages, and even at home using a dipsticks. This can be done in a lab or at home. Now let's come to the first most important thing since we are dealing with children, urine collection. I mean, it's a task if you ask any parent to collect urine, especially the child is less than 2 or 3 years, and especially a child who is not toilet trained. And if it is a female child, it is even worse. So let's just get a little bit of a clarity on the terminology. First is the first morning sample. Most of the times that adults send urine samples, it's always expected to be the first morning sample. So that is the first sample after uh, overnight being without any food or water. Second is a random sample. Random sample is any sample. See, in children, it is very difficult, especially infants, it is very difficult to collect the first morning sample because they are continuously passing urine throughout the night. So random sample is any sample. Now, how do you collect the sample? Sample can be collected when the child is passing the urine in the container that has been provided, or otherwise, if you're not able to do that, then the other option that is there is using a millicom. What is millicom? It's a small bag which is used for urine collection. This is what it looks like. So there is a little different one available for males and females. This is true or valid only for small children, especially less than a couple of years old. So this you can see that there is a sticking which sticks around the vaginal area or the penile area, and when the baby passes the urine, it gets directly collected into the bag. Then the other way to collect sample would be catheterization. Now this would be in very sick children, children who are on catheters already, surgical patients. So where you would collect the sample directly from the catheter. Now, what is this midstream clean catch sample? Again, midstream clean catch sample is a sample that is collected when the child is passing urine. Now, it is the sample where the initial part of the urine you let go and you collect the latter part of the urine. This is very important for collection, the methodology for urine culture, especially if you're looking for it from urinary tract infection point of view, because a little bit of contamination also causes the organisms to grow in the sample that you have sent for culture. So in the midstream sample collection, as I told you, you have to collect the latter part of the urine. But before you do that, you have to clean the either the prepucial area or the vaginal area with simple soap, water, or any antiseptic solution that is easily available. In the males, if you can retract the prepuce, let the initial part of the urine go and then collect the sample. Or in the females, you just separate the labia majora and then collect the sample, the latter part. And last is the suprapubic tap. Now, this is a very, very young infants, especially neonates and paraneonates, where urine collection is very difficult. And especially if you're looking from urine culture point of view, then this is the other way. This is a schematic diagram of where you would tap for collecting the urine directly from the bladder. It's exactly about the pubic symphysis, exactly in the midline. Now we come to the physical examination of the urine. When we have the urine reports, physical examination first would be the color. Normal urine color can be varied. It depends on the concentration of the urine. So it can be light yellow to dark yellow. Most of the times it is amber in color. Then come the abnormal urine colors. So the commonest abnormal colors that we see is either a red colored urine or a cola colored urine. Now that would be seen with hematuria, hemoglobinuria, myoglobinuria. You can get many non-medical causes for the urine being red in color also. So certain food coloring agents, especially beetroots, certain drugs, dyes like phenolphthalein can cause a little bit of pinkish or a reddish color in the urine. Now you can have a black or brown black colored urine. So this is commonly seen with methemoglobinemia, alkaptonuria, tyrosinosis. Methemoglobinemia, again, one has to have methemoglobin in the blood sample to be traversing the kidneys into the urine. Then on orange colored urine is normally seen if the urine is very concentrated or it is very high in urobilinogen content. Normally we see with indirect jaundice. Certain drugs, metronidazole is one of the commonest drugs which causes an orange colored urine, and so is rifampicin. Then hazy urine. Hazy urine would be or cloudy. So, sometimes the cloudiness can be because of cells in the urine. So even few amount of RBCs and lesser number can give you a little bit of a cloudiness. But most commonly that you will see hazy or cloudy urine with urinary tract infection, chyluria and phosphaturia. Phosphaturia most of the times is normal. It is that what we call kachara settling down in the urine when the urine is standing for the long time. It's such as high contents of phosphates in the urine. So now, next in the physical parameters is the odor. So these are all the things that you are going to see in the urine report. So odor, generally it's aromatic. When the urine is standing for a long time and you smell that, it would be ammonical. There are a few illnesses which give very particular or peculiar odors. So like musty, fishy, sweaty feet, maple syrup. So these are seen in different kinds of organic acidemias, maple syrup disease, or PKU. Now, fruity odor, that is a little sweetish smelling in children, a little uncommon, but seen with diabetes. We come on to the specific gravity. Specific gravity normally in the urine, it's a very wide range. I have written a very wide range because you're considering the fact that it's from 1.002 to 1.035. So that would be the most concentrated urine to the most dilute urine. It is, of course, directly proportional to the urine osmolarity. So the osmolarity, higher the osmolarity, the more the urine will be, the specific gravity would be higher. Neonates have a low osmolarity and they reach the level of adult osmolarity by the time they are 2 years of age, because the neonatal kidneys have an inability to concentrate the urine as much as one would like. So it just gives you a specific gravity, gives you a percent as to the concentration capacity of the kidney. Like if you have kept and for an in an overnight sample, which is like a 12 hours fasting sample, if you have given, normally your specific gravity should go up to 1.022. If it fails to do that, That means it is persistently low, somewhere around 1.01, 1.005 or so. There is a possibility either you're dealing with diabetes insipidus or an intrinsic renal disease, especially chronic kidney diseases. What we're talking about CRF, where the terminology is now CKD. When you have a fixed specific gravity, that would require multiple samples. So in multiple samples, if your specific gravity, irrespective of what you have eaten, not eaten, how many hours of fasting, not fasting, you check and it is persistently somewhere between 1.007 to 1.010. It's mostly seen in advanced stages of CKD. And specific gravity of more than 1.035, it could first always think of a contaminated sample. Your container may not be adequately washed or cleaned, or it's not right. A high concentration of glucose, it could be post contrast. Immediately one has done post contrast studies. So next we come on to the chemical examinations. pH, always check the pH in a fresh sample, because on standing the pH tends to change. Interpretation of the pH is based on a suspected clinical abnormality. So you cannot just have one reading of pH. Oh, this urine is alkaline. Oh, this pH is on the acidic side. So it could be something, it could be something. In fact, I would say the whole urine report is going to be based on in toto with the clinical presentation and with the other supporting lab investigations, blood, etc. Not only based on a urine report completely. So you would have acidic urine normally with any kind of acidosis, respiratory or metabolic. You can have it in PKU and alkoptenuria. Alkaline urine normally would be seen more commonly with urinary tract infections. Certain organisms tend to cause, especially Proteus, Pseudomonas, and Klebsiella. Respiratory or metabolic alkalosis, hyperaldosteronism, Cushing syndrome. Proteins are the commonest thing that one would see and which do tend to come positive. I mean, most of the times when we are seeing the reports as clinicians, somehow or the other, we don't pay too much attention to the pH, we don't pay too much attention to the specific gravity, but most of the times the proteins are written as trace 1 plus, and that is where it draws our attention because it is looking like some abnormal value. So normal protein would be somewhere less than 150 milligrams per day. Now this is an absolute value which has to be estimated, or it would be less than 4 milligrams per meter square per hour. Now, as I said, this is an absolute value, and this 4 milligrams per meter square per hour is in a 24-hour sample. So normally what we see is it is reported as nil, trace, 1 plus, 2 plus, 3 plus, and 4 plus on our routine urine reports. So any protein between the range of less than more than 150, but less than 40 milligrams per meter square per hour is considered as proteinuria. And any urine more than 40 milligrams per meter square per hour or more than 50 milligrams per kg per day is considered nephrotic range proteinuria. So that is what is called as heavy proteinuria. And it is the etiology could still be, you could have multiple etiologies with both these kinds of things, but it gives you a better idea what you are likely to be dealing with when you know the range of proteinuria. So when you say nephrotic range proteinuria, most of the times when you see on your your urine protein routine report, it would be either 3 plus or 4 plus, occasionally with 2 plus. Normally glucose is excreted in the urine, but it is in a very small quantity, somewhere around 130 milligrams per day, more less than that generally. Now, presence of sugars in the urine, most commonly seen is with type 1 diabetes mellitus, renal glycosuria, where your Tmax for urinary glucose excretion is lower than what it would normally be, some endocrinopathies, certain drugs, and Fanconi syndrome. Dipsticks, mind you, does not check for fructose and galactose. So especially in newborns, if you are suspecting any one of these two illnesses where the sugar is likely to be because of that on your lab urine report and not on this. So your dipsticks will show negative, but the lab will show positive. So if that kind of a scene is there, always think in terms of fructose or galactose being present in the urine. It could be part of hereditary fructose intolerance or galactosemias. Ketones, acetones, these are the normal ketones that normally one would see in the urine: acetone, acetic acid, hydroxybutyric acid. It is normally seen in starvation. So most of the times, sick children, children who have been with fever for 3, 4, 5 days, generally would have some amount of acetone present in the urine on our regular urine reports that we see. So any prolonged starvation, sick child, not eating well, diabetes mellitus, glycogen storage diseases, and organic acidemias would have ketones positive in the urine. The next would be bilirubin. Everybody knows where bilirubin comes from. So it is presence of bile salts or bile pigments or urobilinogen. Normally, urobilinogen would be positive in the urine, but if it is in very high quantities, one may need to investigate further. So generally, bile salts, bile pigments would be any liver cause most of the times, which would cause direct hyperbilirubinemia. Then blood would be hematuria, hemoglobinuria, myoglobinuria. Now, again, over here, blood, it will all look red. So this is your nitrite test, which is done in the urine, which will come positive, or even on the dipsticks, it will come positive. So you would be able to differentiate between hematuria, hemoglobinuria, myoglobinuria based on your further microscopic examination, not only on the basis of uh, the chemical examination. So now we come on to the microscopic examination. Normally, one would see less than 2 RBCs per high power field in a centrifuge sample. Anything more than 5 is considered abnormal and needs to be evaluated. One off value has got no meaning. So if you have more than 5 episodes in, I mean, more than 5 RBCs per high power field in one of urine, maybe repeat after a few days, and if it is persistent in multiple reports, then it needs to be evaluated further, because it could just be the beginning of some renal parenchymal disease, which we need to evaluate and come to an early diagnosis. Pus cells more than 5 normally would be less than 5 per high power field in a centrifuge sample. If the sample is uncentrifuged, some people consider more than 10. Epithelial cells are the normal slough renal tubular cells. By itself, they have no meaning unless and until they are very, very large in number. Then it could suggest some problem with the collecting system. Yeast, normally one would not see yeast, or occasionally one does see yeast in the urine. Again, it depends on the clinical background and the setup that you are dealing with. If it's an immunocompromised individual and your yeast is positive, you would give it some significance. But if it comes without any reason in a normal child where you're just investigating short history for PUO, yeast positive, maybe no meaning. It has to be a significant number of yeast cells present. Same thing holds true with bacteria. Contaminant in the urine can cause higher number of bacteria, especially if it is not being collected properly. The commensals of the urethra, the commensals of the vaginal area can be seen in the microscopic examination. Ova and parasites, of course, they are self-explanatory, though very, very rare in the urine. And most of the times, first I would go back to say that the sample is contaminated with stool. Now, casts and crystals. Casts should always be seen in unsponged samples. They are generally the cells from the direct convoluted tubules and the collecting system, collecting tubules. They are generally hyaline or cellular. I would just go a little further on the type of casts in one of the next few slides. Casts generally would be hyaline casts or RBC casts or WBC casts. What are hyaline casts? They are generally proteinaceous material that is there. So there is some amount of proteinuria which is going on, and a state of dehydration, the proteins tend to get denatured and form casts. If you have very high number of pus cells in the urine, probably urinary tract infection, severe, and especially the upper tract, it tends to give WBC casts. RBC casts are again because of some renal parenchymal disease most of the times. So if they can be just simple proper casts, or otherwise they can be multiple shaped. So if they are in different shapes or distorted, it is more likely to be a renal parenchymal disease. Then we come to crystals. Most of the times crystals are generally few, and we do get reports very commonly saying calcium oxalate present, calcium phosphate present, etc. So now if they are in a very large number, And if you have a clinical setting which is maybe indicative of it, then one would give significance to it and evaluate further. So now I come on to special tests. Now, special tests, this generally one would not do. So you would go backwards now to what your clinical setting is, what is there on your urine routine report, and based on that, you would go ahead and do these tests. So urine osmolarity would be anything between 300 to 900 or milliosmoles is the osmolarity in children less than 2 years, and it goes up to 1200 by the time adults beyond 2 years of age. Now, if you have a ratio, I mean, if you take the urine osmolarity is much more than plasma osmolarity, it would indicate renal failure, especially a pre-renal cause. While if it is same in both, that is the urine osmolarity and the plasma osmolarity are similar, it would indicate acute tubular necrosis. Urine electrolytes. Again, now urine electrolytes can be done in a spot sample and can be done in a 24-hour sample. The evaluation is going to be based on what you are, again, clinical setting and what you are looking for. So most of the times, sodium calculation is mainly for FENA, that is your fractional excretion of sodium. It is a renal failure index. Again, it will help you to differentiate between pre-renal and post-renal, renal causes. High potassium is generally seen in RTA, especially your urinary spot. So potassiums would be way higher and your serum sodium would be lower. Chlorides would be high generally with Bartter syndrome, where you have a clinical setting in the this where your blood gas is showing alkalosis, metabolic alkalosis. You have hypokalemia associated with high chloride excretion. Now, urine protein creatinine ratio. Now, this is where it is not possible to do a 24-hour sample and you want to quantify as to the amount of proteinuria that the child is having, especially if you are a little confused or want to differentiate between nephrotic range proteinuria and proteinuria which is abnormal. So then you can quantify it by just doing a simple ratio, urine protein creatinine ratio. So 0.2 is the normal ratio that one would see. Somewhere between 0.2 to 2 is proteinuria, which is significant but not nephrotic range, and more than 2 is considered nephrotic range proteinuria. Again, this is little more of a screening test. One will need to confirm it by doing the 24-hour sample, as I had mentioned earlier. Urine calcium upon creatinine ratio. This is something that we normally do in children because, as you know, that stones or renal calculi are a little uncommon in children. Sometimes you have unexplained hematuria. You don't even know what's the cause. One of the reasons is because of calcium creatinine. And these days, all children have been started on vitamin D3 right from the time newborn period. Sometimes the parents inadvertently land up giving very high doses and the child develops hematuria. It's because of hypercalciuria. So this is a screening test where your urine calcium by creatinine ratio should be less than 0.18. If it is coming more than that, that means it is hypercalciuria. You need to evaluate further by doing a 24-hour sample for confirmation. Urine culture, again, very specific test, especially where you have significant number of pus cells in the urine and you are suspecting urinary tract infection. You have to have a midstream clean cat sample or a catheterized sample or a suprapubic tap sample for this preferably. And 24 hours urine test, as I told you, are specific for particular illnesses. So one would be proteins from the point of view of nephrotic or non-nephrotic range proteinuria, calcium for confirmation of hypercalciuria, evaluation of children who have calculous disease, that is stones. It can be part and parcel of evaluation of children who have nephrocalcinosis on the sonography as part and parcel of some other illness like renal tubular acidosis or medullary sponge kidney. Oxalates, generally it can be primary hyperoxaluria and part and parcel of calculus disease or secondary hyperoxaluria. Uric acid and citrate. Generally, most of the times, if you see a child with stones, commonest thing you would get is low citrate. They are hypocitratemic and they just need to have citrate supplement to have the stone, no recurrence of the stone happening. Now, this is just a clinical urine sample of three different patients. They all look similar if you try to interpret. So that's why this is one of the best slides that I like. It confuses you, but it also gives you an insight as to what you are likely to be dealing with. So if you see the first sample, let's go by the first sample. The color would be, it was reported as smoky. It is showing a specific gravity of 1.020, pH is 5.5, proteinuria 2 plus, sugar absent, blood 2 plus, ketones absent, pus cells 15 to 20, RBCs 250 to 200, and bacteria few, cast and crystals, RBC and hyaline cast. So as I had mentioned, hyaline cast part of proteinuria, RBC cast part of hematuria. So now if you see this, what does it look like? It looked like some glomerular disease. Does it look like UTI? Maybe, maybe not. Why maybe not? Because if you see the number of pus cells are way fewer than the number of RBCs. The RBCs are much more higher in number significantly. Most urinary tract infections would have way more number of RBCs, I mean WBCs than the RBCs. So this most likely would be suggestive of some glomerulonephritis. It could be part of AGN or any other illness. Now let's see the second sample where the urine is clear. At times it can look a little hazy. Specific gravity 1.015, pH is 6, proteinuria 4 plus, sugar absent, blood absent, ketones absent, pus cells 3 to 5, RBCs 1 to 2, bacteria few, casts and crystals nil. So if you go to see, the whole report is practically normal except for heavy proteinuria 4 plus. So it would need a further evaluation. You have to see the clinical setup. Now, again, I come back. Could this be an acute glomerulonephritis? Yes, it is possible, but a little uncommon. What else? More likely to be a nephrotic syndrome. Third sample, which is a hazy urine. You're seeing specific gravity of 1.020, pH is 7, proteins 1 plus, sugar absent, albumin 1 plus, blood 1 plus, ketones trace, pus cells 80 to 100, RBCs 15 to 20, bacteria present, casts and crystals, again WBC casts. Most likely urinary tract infection. You have some amount of proteinuria, some amount of blood, but you see the number of pus cells, they are significantly positive, much more than the others. So if you see these three samples, there is quite a lot of overlap. They all look very similar, but the interpretation is going to be different because you're going to be interpreting not only the urine report, it is going to tell you more likely what it is, but you have to see the clinical setup along with the urine report and the other lab investigations, blood investigations, along with the whole picture. So don't make your interpretations only based on your urine report. See the patient as a whole, where urine analysis is just a part and parcel to help you get an insight into the likely possibility of what illness you're dealing with. Thank you.
Thank you, sir. Any questions from the participants? Anyone would like to ask any questions? Thank you so much, sir. I don't think there are any questions. If we have more questions, I will let you know.
Okay.
And I'd like to introduce, thank you, sir. I'd like to introduce our next speaker. Our next speaker is Dr. Paresh Desai, sir. He is a senior consultant in pediatric medicine at SRCC Children's Hospital. And sir would be taking the topic on animal bites in children. I welcome sir on behalf of all of us.
Good afternoon, everyone. I hope I am audible.
Yes, sir. Audible.
Okay. So, we are going to talk on animal bites, and family doctors are the first people who are consulted when there is animal bites. There is always panic, parents, grandparents, all worried about their child being bitten by, usually it is dogs, but could be cats, rats, monkeys, and now that people are traveling, even forest animals. The question is that everyone knows what animal bites are about. All of us, pediatricians, consultants, general practitioners, family doctors, but nobody is really extremely clear. So, my attempt to do this is to make it extremely simple. And please, you know, uh, remember the main salient points, because the most dreaded disease here, rabies, has absolutely no cure. And once you get it, it is universally fatal. There is no hope. I am old enough to have made death certificates for over 15 children with rabies. Luckily, none for the last 25 years. And I wish to, not make any more while I'm practicing. And you should all aim for the same goal. Let's start. Next slide. Arrow से राइट क्लिक, ये तो किया मैंने. So, you see these headlines all the time. This is about 2, 3 weeks, 4 weeks ago, rise in rabies. Nahi audible? No. Yeah, rise in rabies, dog bites, and so on. And not just bite, dog scratch too causes rabies. That is another headline. मेरा योगदान देना. You headline डाल दो ना. Beautiful. About a lady in Chakan, which is midway between Pune and Nasik, being attacked by a pack of dogs and died. Yes, sir. So in animal bites, we have dog. This is in the order in all India frequency. Dog, and surprisingly, monkey bites outnumber cat bites. Rats, fox, mongoose, coyote is an American animal. Jackals we have. Skunk also we don't see too many here. Very few badgers, and the bats, which really cause rabies, are almost non-existent in our country. So in India, about 90 lakhs, so almost a crore animal bites occur. That comes to around 25,000 bites a day. And the majority of the bites are dogs. And majority of the dogs are the unvaccinated stray dogs. Cat bites also are more than 60,000 a year. The World Health Organization reports around 18,000 to 21,000 deaths due to rabies in India. The Indian Council of Medical Research says it is 1/4 of that. But this probable discrepancy is because rural cases in India often go unreported and they are classified as something else. It could be encephalitis, strokes, it could be anything, and therefore there is underreporting. Children and elderly are the main victims because the middle-aged people and adults can run away from dogs. It's the children who cannot, and the elderly, because they are infirm, cannot escape these. Coming to cat bites, which are less common in India than dog bites or monkey bites. And they usually, first of all, if you know cats, they hardly want to bite. And the only way the cats usually are bitten are by mistake if someone steps on their tail or steps on them in the dark. Otherwise, biting is not their defense. It is scratching that they do when they want to attack somebody. And there are other diseases that are caused, like cat scratch disease, which is not at all uncommon. The bacteria is Bartonella, but that name. What happens is there is a papule followed by lymph nodes enlargement in the regional area in 1 to 2 weeks, and it resolves in 2 to 4 weeks. But it is painful that time. And to diagnose it, you need indirect fluorescence assay and ELISA, which are available now. And the drugs are very simple: rifampicin, gentamicin, ceftriaxone, sulfa also are all good, and they have a complete cure. Rabies due to cat bites technically is possible, but thank God that the cases are very rare in India. And the last reported death was about 12 years ago. Other bacterial infections are far more common. Scratching by cats, much more common. In the end, I will tell you what to do if you do get somebody who's bitten by a cat. Now, rat bites, because we have a huge population who lives in the slums, even in low-cost housing, there is a huge population who lives in small houses, one-bedroom hall kitchen houses and chawls and so on, wherein most of the people are sleeping on the floor. Rats will not come on the bed, but on the floor they are in the night, nocturnal animals. And one of the most common problems is rat bite fever, which is seen. Luckily, rats in India do not cause rabies. Otherwise, we would have had lakhs of deaths because of rabies in India. And the Streptococcus moniliformis is the one that causes rat bite fever. It looks like any other viral fever, chills, joint pain, vomiting, rash. But untreated, it can lead to encephalitis and even myocarditis, endocarditis also, vegetations also, which is again rare. Mostly everybody treats it with something or the other in the first few days and it doesn't go on to that. Leptospirosis, every one of you must have seen in the monsoon, and that is because the rat urine contaminates pre-existing wounds and the scratches on the feet. And you walk through flooded streets in Bombay, there is high fever, muscle pain, red eyes, and jaundice. So this is a monsoon illness. Every year we have cases. Normally, again, treatable, and you don't really need to, the patient doesn't need to die in this. Monkey bites causing rabies, again rare. Monkey bites by itself are rare. The reason monkeys are biting now is because there have been, all these Bhandari fellows have left their monkeys in the road. And sometimes, again, monkeys don't bite unless provoked. In the forest areas and all, it is possible. And if you are bitten, the monkey has been bitten by a rabid dog, which again is rare, then they can be rabies because of monkey bites. Monkey bites cause other Kaisanur forest disease and all, which are far more, again, rare, slow viral infections. And if you are suspecting rabies, they do require, if you are in the city, a post-exposure prophylaxis, which we will come to in the end. The usual causes, the problems are bacterial infection. So you wash the wound with soap and water, use betadine, and you give rabies vaccine 0, 3, 7, 14 days. Other fox, mongoose, squirrels, coyotes, bats have the same protocol. Now let's come to the main part which everybody is more interested in, that is dog bites, which is where, because we are in Bombay, we are worried about dog bites. We have the highest number of rabies deaths in the world, that is India. And everybody knows that rabies once happens is 100% fatal. And most rabies cases in India are because of dog bite. Other risks are bacterial infection, tetanus, hardly any because of the extensive DPT coverage now, muscle tendon damage which can be repaired, and the psychological trauma of dog bites. Children, adults, lifelong they are scared of dogs. And dogs can sense people who are scared of them and tend to attack them little more. Urban India, like Bombay, has a very, very high stray dog density. If you go abroad in London, New York, wherever you go, there is no such thing as a stray dog. Every dog is in a home or in a kennel or somewhere. They are not dogs and they are universally vaccinated. Poor garbage management in India, where the garbage is on the roads and streets, so the dogs gravitate towards that to eat because they are hungry. The feeding areas for dogs and whatever are very close to residential societies, complexes. So high human population. Children in India do play unsupervised all the time, and children have a natural curiosity to go near dogs. Then walking back in the night after a movie or walking back late in the night encounters, these dogs are roaming around, and this is a very big danger in the middle of the night. In the day, they may not come close to you because there are so many people. Night, you are alone. Also, dogs have now in India, as you can see from news reports, they have become pack animals. There are 2, 3, 4 dogs who attack in unison together, and it's very difficult to then run away. So, India accounts for 36% of the world's total cases and more in children and elderly, like I told you, reporting discrepancies and a total ignorance on as to what to do. So what happens? So the incubation period of rabies, so God is kind always. So if this is such a fatal disease, it has given you a little time. Most diseases to prevent, you give vaccines before the disease occurs. You give polio vaccine before you get polio. You get diphtheria vaccine before you get diphtheria. But rabies is something that you can vaccinate after being bitten by it because it is a slow virus disease and you have 1 to 3 months lag period usually. The bite site, when it attacks, it is a saliva which is in the dog's saliva which enters with the virus stays. It goes into the peripheral nerves that are around. And from the peripheral nerve, whether it is in the foot or the hand or wherever, it will go to the spinal cord and reach the brain. The symptomatology or the problems of rabies only start once the virus reaches the brain. So straight away one must understand that I like a bite on the leg more than a bite on the neck, more than a bite on the face, because the transit time for the leg is a long time. You have time. Hand is less. Face you may sometimes have just 1 day. And even that what you treat may not be enough and you may still succumb. So therefore, the further the bite away from the brain or the head, the better. Patients absolutely are normal while the virus is in transit. You have been infected or bitten by a rabid dog, you are incubating the virus, but there are absolutely no symptoms. And later, when they start, it is vague to begin with fever, headache, fatigue, nausea, anxiety, irritability, pain, tingling, itching, burning at bite sites. Please use these as red flag signs when somebody gives a history that he was bitten or attacked by a dog. The neurological rabies have two types. One is the furious rabies, extreme agitation, extreme hyperactivity, confusions, hallucinations, and what is most common, hydrophobia. Pani dekh ke darta hai. So hydrophobia because of the saliva, these swallowing issues, aerophobia meaning scared of breathing fast, drooling because he can't swallow the saliva, and then finally convulsions. Paralytic rabies, which is the second type, is gradual muscle weakness similar to Guillain-Barré syndrome, ascending paralysis. There is a loss of reflexes, coma, and this form is often misdiagnosed as encephalitis, peripheral neuritis, and so on, or Guillain-Barré syndrome. So then, as a general practitioner, when do you suspect rabies? Any dog bite, especially straw dog bite, any lick also, you suspect rabies. Monkey, bat, cat bites. If the wound has not been looked after and there has been no post-exposure, even a vaccine given, please suspect rabies. It's better to suspect. The key point is that once neurological symptoms appear, there is hardly anything that can be done. But if treated before the neurological symptoms, almost 100% preventable. Please pay extreme attention to what I'm saying now. Immediate post-bite care is wash. And the washing should be done with soap and water. Soap is very useful and it has to be going on for 15 minutes, not just 5-minute wash or 2-minute wash. Just keep it under running water and keep on washing and flush thoroughly, because mechanical washing removes the virus from the site of the bite. And that is very important. The less virus there is, the better you are off. Betadine, chlorhexidine, spirit. My one teacher who was a master of rabies from Ludhiana said, urine also is great. If you have nothing, you are in a jungle, use your urine to clean the bite. Please, no haldi, chili, mud, oil. If possible, and not too much bleeding, avoid bandage. Keep it open, because bandaging increases the virus transit. Avoid stitching unless absolutely necessary. But sometimes when there are horrible bites, you have to stitch. Stitches are given little loose stitches just to cause approximation of the two edges of the skin. Then let's classify. So if it is touching or a lick on intact skin, and you can guarantee that, no treatment is necessary. This is the class 1 exposure. A class 2 exposure is a minor scratch, but you can't see bleed, and there has not been any licking or whatever, then a vaccine will suffice. The one that you get Expirab and Rabipur and so on, which cost 500-600 rupees. So everybody can afford it, and it's available in government hospitals extremely easily. The third class of bite is the problem. That is bite where there is a bleeding wound or there is a lick on broken skin. You need to give vaccine, but also rabies immunoglobulin. What this means is vaccine, when you give it, it takes time. The earliest the vaccine response will be within 3 days. But normally it can take up to 2 weeks. While rabies immunoglobulin, when infiltrated directly on the wound, will start acting immediately. These are ready-made antibodies. When you give vaccine, you expect the patient's immune system to make the antibodies, so it's going to take time. So it's like ordering food home. You order a paneer curry at home, you get it ready. Otherwise, you have to buy the milk, make the paneer, make the masala, and so on. So that is going to take time. The vaccines that are available are now all inactivated killed vaccines, and the most common ones are the purified check embryo vaccine, PCECV, which is what is Rabipur brand, which is extremely common in use. Purified virocell rabies vaccine, Vaxira, both are equally effective. I mean, there is nothing to choose between the chick and the human cell line. Maybe the cost. Rabies immune globulin came in the mid 20th century, and the first immune globulins which started saving lives of people was using horse serum. So the horses were injected with the rabies virus. Horses don't get rabies, so they just make antibodies. Then you take out their blood, try and purify as much as possible, and then inject it into the patient. The death frequency reduced, but there was, as expected, because of protein in it, serum sickness, that is a type 3 anaphylactic, type 3 immune reaction, allergic reactions were extremely common. Sometimes they used to cause problems or even deaths. Then the equine rabies immune globulin came, which was more purified, and this was what was used. There were improved purification and hence reduced reactions. Also, it became cheaper. But all senior doctors will know that this was the vaccine which was given पेट के अंदर, because there was large volumes to be injected, 10 ml, 15 ml, 20 ml, and they had to be injected subcutaneously. So there is no subcutaneous space other than the abdominal wall where you can do. And the doses were also many, 7 doses, 14 doses. So this old, anybody who's above 55 here will tell you, कि 14 इंजेक्शन पेट में लिया. So that is the kind of vaccine. It is still given, but because of the non-availability of the others or ignorance. But this is, it should not be in the advanced world. No one uses this. So the biggest development here is the human rabies immune globulin HRIG, which came in the 70s and 80s, which is very, very recent, less than 50 years ago. And it developed from hyper-vaccinated human plasma donors. So human beings were given rabies vaccine, not rabies virus, and given 5 doses, and also they have immune globulins, IgG, which you then isolate and use it as human immune globulin. There is also a modern refinement which you remove, only give the FAB part 2 segment. So it is even less allergenic, but cost goes up quite a bit when you have a modern one. And the latest thing is now monoclonal antibodies, which should be what we should be using. So these are the key milestones in rabies. Pasteur developed the first vaccine in 1885. Then animal serum came in 1900s. Then, like I told you, the equine immune globulin came in 60s. Then the refined globulin came human in 70s. Purification techniques improved in the 2000s. And now after 2010, last 15, 20 years, 15, 18 years, it is monoclonal antibodies. And this is this HRIG, the passive dose vaccine is 20 international units per kilogram body weight, and you infiltrate half of the dose around the wound, all around, and the other half on the deltoid muscle as far as possible. The drug is Revishil, which is the most common Serum Institute and universally available. Chirorab, Abhairab are not always available. And these are always available, the local chemists may not keep them. But all hospitals, so if you are in this C ward, then it will be, Saifi Hospital, Breach Candy Hospital, Bhatia Hospital, pharmacies will always have. Of course, there is always the pharmacy shops around KEM Hospital, where they will always have this. And you have to do it, these are all day and night. So you have to do it. You can't wait till tomorrow morning to give it if the dog has bitten in the night. There are 2 kinds of preparations available. One is the 50 units per ml and the 100 units per ml. And the dose, please note, this is the most important slide. 3.33 or let's say 3 units per kg per body weight. So for an adult, so is 50, 60 kilos, you need 200 units. So you need 200 unit vials. You can infiltrate half of that around the wound, half in the deltoid. But if this is a child, then you calculate by body weight. So 20 kilo child will need about 70, so on. It's better to give a little more than a little less. Rabies vaccine course must be started on the same day. So at 10 p.m. somebody comes to me, the child is say 12 kilos and he's been bitten. And 12 fours are say 48. So I will give 50 units. I will order this. I will half inject around the wound. the other half immediately on the other deltoid. If the deltoid muscle not developed, then I can use the thigh. And similarly, on the other deltoid, I will give Rabipur or Expirat vaccine also. And all 5 doses, 0 day, 3 day, 5 day, sorry, 0, 3, 7, 14, and 28th day. This is Rabies Shield, which is universally available, and there is no excuse for not giving it. In fact, you can be liable for neglect if you lose somebody to rabies because of not having given this. The rabies vaccine schedules are straight away 0, 3, 7, 14, 28. You can even do 30. So if today is 18th, so if today you have been bitten, then today 21st, 25th, 25 plus 7. So 2nd April and then 18th April. You can use like that. And please keep this. The rabies vaccine vials also contain this pamphlet which has this. If you want to save money on the rabies shield, you can use intradermal because you have to use one very, very little. But intradermal is not easy to give. It's like giving Mantoux test or BCG vaccine. And the skill needed to do this is quite a bit, and you have to be in practice. So let's not talk about this. Use the other way. Then parents will tell you, but मेरे बच्चे को पहले कभी vaccine already given है. So then they need only to be given a booster. And that is on day 1 or the first day and then 3 days later. Because they already have the vaccine. They've taken a 5 vaccine course before. So they have immunity. But we don't want to take a chance. So we give it like a booster. There are certain populations where you should give pre-exposure prophylaxis to. That is veterinary people, animal handlers in labs, lab workers, people who work in the forest, zoo, and the dose is as per 0, 7, 24, 3 days. Three doses is what you give. Now the new pre-exposure prophylaxis is also given. You know, in children, there are some 10-year-old, 8-year-olds who are working for welfare of stray dogs. And they are very much into playing with stray dogs. And there are stray dogs in every society or outside every society. So please, better to give these people this. This is the kind of children they have. And again, because, you know, rabies is, when it happens, is very difficult to do anything about. That's about it. If there are any questions.
Sir, there is a question in the chat box.
Yes.
I'll just read it out.
Yeah.
Dr. Afreen has asked that for class 3 exposure, is
Ji.
it important to give immunoglobulins again if the patient...
Yes, and I'm very loud. 3 yeses.
Any other questions? Thank you, sir. Thank you so much, sir.
Thank you.
Our next speaker is Dr. Archana Khan. Madam is a consultant pediatric rheumatology at SRCC Children's Hospital and at JJ Hospital. She has multiple research and publications in national and international journals. She's actively involved in educating fellows, organizing workshops, and participating in international research projects, mainly to help further the understanding of pediatric rheumatic diseases. I'd like to invite her for our masterclass today. Her topic is about simplifying rheumatological diseases in children. Welcome, ma'am. Ma'am, sorry to interrupt you, but if Dr. Paresh Desai sir is still there, there is one more question in the chat box.
I'm still there.
Yes, sir. So if a patient has taken a day 0 dose and misses 3 and 7 third and the 7th day dose, do we need to restart the schedule?
Absolutely. There is no harm in taking it. Already you are late. Let's hope nothing happens.
Thank you, sir. Dr. Archana?
Yes, yes.
Yes, thank
Give me 2 minutes. We are just doing the slides. Okay. Good afternoon, everybody. So the goal today is very simple: how to recognize rheumatological conditions, treat if you can, and refer timely. A child is not going to come speaking rheumatology. A child will come with simple symptoms that can look like anything. It can look like infection, trauma, illnesses, malignancies. And then, how do we actually tease out these diseases and land up with a diagnosis that maybe we are dealing with something more sinister or rheumatological? Because these diseases, although they are less common, they are quite commonly relevant to us. Why? Because the child may land up with a lot of disability, lower quality of life, and timely diagnosis can really, really help us in treating these children well and giving them a good quality of life. Especially so because in India, with a large population, already these diseases are lurking around everywhere. Huge consanguinity belts, especially states like Telangana, are having at least 39% consanguinity. Even if you don't have consanguinity, there are lots of endogamous marriages. So do not feel that just because there is no consanguinity, a genetic disease cannot present like this. And I'm sure everyone who is present today in the audience will definitely find these cases coming to their clinics. And so it is time to think, because if you don't think, you will not pick up. If you don't know, you will not pick up. And at the end of this session, I'm sure that all of us would be more sensitized and we will be able to pick up these diseases, which we generally deal with in pediatric rheumatology OPD almost every day. Now, I'm not going to really torture you with these names. These are not important. The diseases could fall into any of these categories, which I don't even want to name too much. But the good part is that if you have to take away one message and one slide from here, this is the slide that all of you should take away with. All our rheumatological cases would enter through one or more of these doors. Fever, fever which is not going, which we think is infection which is resistant, fever which is coming again and again and cannot be explained. Pause, think. You might be dealing now not with infection and common things that we see, but with a rheumatological disease. A limp, a child may not complain of, but you might find a child sitting and not moving one particular limb, or it may present as simple delayed milestones. We have children who come to us with delayed milestones, and we find that there are some joints coming up. So these are the cases that should alert you to find out a rheumatological cause. Arthritis, I will be dealing with a few more slides ahead, so I'm not specifying here. Any kind of rash, a first thing that goes is allergy. And of course, why not? Because that is the most common. But if this allergy is not getting treated, if it is coming, especially so with systemic symptoms, lots of fever, lymph nodes, something happening in the liver, you must think that maybe this rash is not simple eosinophilic allergic rash. It could be neutrophilic rash, which comes with autoimmune or autoinflammatory diseases. Eye, which is like a window to most of the body, but especially so for rheumatological diseases or extraarticular disease or organ multisystemic. And if you feel that these flare, FLARE, if these symptoms are not getting okay in a child whom you've been following for long, you are most probably dealing with a rheumatological disease.
and you can always go back. It's not important to diagnose, it's more important to pick up these children, then see if you can treat, and then refer timely. So, coming to one major point before I go on to the rest of my slides, a child walks in with a joint problem in your clinic, may not be rheumatological, could be simple infection which you can treat, could be most of these patients we also label as growing pains. But growing pains is in a certain age group. It is not rheumatological. But even if it's not rheumatological, you have to be aware that infections, malignancies, growing joint diseases, how they can come. Some joint problems come only with increased flexibility in the joints, which are called as hypermobility joints. They are not strictly rheumatological, but if you could pick those diseases and tease them out, it would serve a lot for the care of our pediatric patients. Like I told you, now we'll go to a different set of slides and again know what are joints, because joints are something that is intimidating when the patient walks in. But I will give you a simple formula. A child who walks in with this joint complaints, you're supposed to ask only 3 questions. Is it arthritis? Is it acute or chronic? And most important, is it inflammatory, non-inflammatory, or sinister? You answer these 3 questions, and trust me, you will have to refer a few, but the rest of them you will be able to treat yourself. Coming to, is it arthritis, meaning inflammation inside the joint, or is it arthralgia? If you can see objective signs of inflammation, if you can elicit swelling, warmth, erythema or redness, pain or tenderness, pain patient will complain of. Tenderness is when you move the limb along the direction of the joint and you find that the patient is wincing in all the directions. Yes, the patient has pain which is originating from inside the joint and restricted range of motions. If these things are missing, you are not dealing with an inflammatory arthritis. You might be dealing with something periarticular, you might be dealing with something in the muscles. So, these are the inflammatory signs that if you could answer and look at bedside in the clinic, you will know what you're dealing with. Now, to elicit in a simple, these are live case scenarios. 2 cases, 3-year-old, 5-year-old, very similar presentation, chronic presentation of 8 weeks and 7 weeks. The second child had occasional fever, fatigue, nothing that to raise the alarm. ESR is almost similar, not too much raised, with a single joint. Both these cases had presented with a single joint. From what we talked in the previous, we can see that yes, we are dealing with inflammatory joint. But are we dealing with a rheumatological joint or are we dealing with something different? On further investigation, because it's a single joint, we went ahead with biopsy. As a side point, I would like to tell you that we do not biopsy all inflammatory joints. Only if it's a single joint involved, you have to biopsy to know the diagnosis to which you are arriving at. So here in the second child, we found that child had COX. MJIT was positive and culture grew. And the first child turned out to be oligoarticular GIA. Again, it is not the diagnosis which is important. I've just highlighted it to emphasize the point that all joints may not be rheumatological, some could be infections, and some could be rheumatological. You have to be an astute clinician and observer and go in the right track to know. Now you know that you're dealing with arthritis. Ask yourself the question, is it acute or is it chronic? And you will see in the next slide what a difference this can make. Now you see again 3 children, similar finding, different duration. Now this child who comes to you with 4 to 5 hours duration with joint involvement, lower joint knee involvement. What would you think of? Sit back and think. Would you call it JIA? Would you refer this child to a rheumatologist? Or would you go a little more deeper in your thought and think that for in such a short duration, who could present to you? It could be trauma, it could be bacterial arthritis, it could be coagulopathy. You will not have a JIA coming within hours or even within weeks if the history is right. Not less than 3 weeks, because JIA diagnosis itself starts after 6 weeks. Now, if the child comes not hours but within weeks, yes, this is where you could be dealing with something inflammatory in nature, connective tissue disorders, vasculitis. But again, I would keep the first differential as infections, viral vaccinations, malignancies, mechanical as in hypermobile joint and things like that, and maybe onset of GIA, but you will not give him a label till we cross 6 weeks. And mind you, even after 3 months, we do get infections like Cox and Brucella. Brucella is something that you could elicit only in history. Time and again, we have found Brucella infection, and patient is being treated only for GIA for long. Not a very common infection, but not something that as clinicians we should rule out, because it could save a lot of misery to our children. And one more very important thing, pain is not a predominant feature in JIA. If a child comes with too much pain in the joints, please do not think JIA and rheumatological. Go on to take a screenshot of this if you want and go come back to this chart to see if you're dealing with something different. And lastly, and maybe the most important part of the joint that you have to answer and ask yourself is it inflammatory, non-inflammatory, or sinister? A simple chart will give you the answer. Most important history, morning stiffness. One question you ask the patient, दर्द सुबह ज्यादा होता है दोपहर या रात? If the patient tells you दिन के कोई भी टाइम पे होता है, रात को सोते वक्त होता है, move away from a diagnosis of JIA. Morning stiffness, gelling, or improvement after the patient gets up or after sitting for a long time starts walking, that is inflammatory joints. Any time of the day is not inflammatory, and night awakening is something which should be like an emergency, and immediate referral has to be done to a tertiary care center. Sinister joints will keep a child awake at night. Infective joint may be septic, but otherwise generally not. JIA joint, definitely not. If a child wakes up at night and comes with some abnormal CBC, refer the patient immediately. This is actually not a forum to tell you how to look at joints and how to examine, but if you get into a habit, it's a 60-second examination, and each and every joint of the body can be seen. You can scan this QR code, and that YouTube video would be on your phone or on your device right now. I will leave it here for 10 seconds just so that you have this video. If you make it a habit and if you practice it even in 5 patients, I can assure you in primary care, you're never going to miss a joint which is inflammatory. And after asking those 3 questions, you're sorted with the arthritis part of rheumatological diseases. I can come back to this later, or maybe Dr. Rujul would share it if somebody needs it later on. This slide is just to tell you that even whatever joint complaints a patient walks into the clinic with, these are the missed joints. Starting from the last picture, what do we see here? Can anyone know which is the joint involved here? If you see carefully, there is retrognathia. When would you get that? Apart from familial, if parents have, children could have. But generally, what do? We just say, okay, this may not be important. The child looks like that. But this child had chronic involvement in the TM joint, temporomandibular. And this is the chronic after effect of TM joint involvement. Hand joints often missed because patients will come with joint in the knee joint or ankle joint, and we forget to look at hands. Cervical. Tell the patient to look up, down, right, left. You will find all this in the PGALS video that I've shared earlier. And do not forget to look at these joints because it can lead you to a completely different diagnosis or the category of JIA. And most important slide, again, this may be the second most important slide. It's a very, very significant figure if I tell you that 1 in 10 patients of JIA develop uveitis. If you're sure you're dealing with a JIA patient, or a JIA patient is following up with you, most of the times these patients like to go back to their primary physicians. It's a good idea to know that many of these patients could develop uveitis, which could be silent or it could be screening. What is more dangerous for us? The silent variety. If in a JIA child you get back papers from us and you go through the papers, you find ANA positive, and a joint problem which has maybe resolved, it becomes your duty to keep on monitoring the child for a long time, 5 to 10 years, to look for an eye developing uveitis, which may not even appear as a symptom in a child. There'll be no redness, there'll be no pain, but that uveitis would be causing silent blind eye, which would be picked up later on. So, an ANA positive JIA child, please keep on screening them every 3 to 6 monthly, maybe twice a year, to see if nothing new is developing. It does not correlate with the activity of the inflammatory disease. Even if you've treated the child for oligo or a poly-GIA, the uveitis may develop. Second is a screaming, loud, red, painful eye. HLA-B27 positive children. Not only children, even adults. I'm sure many of us here are dealing with HLA-B27 positive patients. At 2 o'clock, this patient gets up and phones you that they have a red eye. You do not wait till 3 o'clock also. Patient has to board the bus, train, car and reach the hospital because this is acute blind eye and one of the only emergencies in rheumatological diseases. So now you know how to kind of diagnose if you're dealing with inflammatory, non-inflammatory, arthritic, joint, infective, or rheumatological. You know what you're going to especially look for if ANA or HLA-B27 is positive. And these are the primary tests that we would do, not to diagnose. We are not doing these tests to diagnose JIA. We may do these tests to diagnose infection, but to know what is the activity of inflammation inside the body. The inflammatory markers would be higher. There could be leukocytosis. Urine, if it is showing RBC or proteins, you're dealing with a rheumatological condition where vessels are getting inflamed. Vasculitis of any cause. Multisystemic involvement. If you find a child is coming with infection and you feel it is not getting treated or she's again and again coming, but there is some transaminitis going on, there's urine which is showing a little bit of 15 to 20 RBCs again and again, beware, you might be dealing with a vasculitic condition. Ferritin becomes important in specific cases, which I would want all of you to know. If any child comes with high-grade fever, even if it's plain dengue, all of us are treating dengue. It's not seen only in rheumatological diseases, macrophage activating syndrome, or HLH. Nowadays, we are seeing a lot of post-dengue HLH coming up. So a higher ferritin is a very good indication that maybe you're going into an hyperinflammatory response. X-rays. We have patients coming with stacks of X-rays of almost all the joints which have come up in the patient, or even if there is no arthritis, even with arthralgias, X-rays are taken. Please remember that X-rays are not going to serve the function of showing you the inflammation inside. It will show you fracture. It will show you calcification. You can rule out other things. So it could be adjunctive to rule out, but it is definitely not going to diagnose inflammatory arthritis. If at all, we might need to do a sonography or an MRI. So please stop taking repeated X-rays of patients who present with joint complaints or joint disease. 3 slides now. I've put up very specific slides and maybe it's not going in a flow, but these are the takeaway messages because these are the problems that patients come to us with, and these are the referrals that we get from primary pediatricians and physicians. And maybe this audience would be wiser after today as to when to do ANA. Not to diagnose. It's not a panel test in any rheumatology condition. Only and only if you want to diagnose connective tissue disease, meaning JDM, scleroderma, not for joint, not for GIA, not for any other thing. And if you have a patient of GIA and you happen to do an ANA, it would only give you that this child has more chances of developing uveitis. So maybe you have to monitor them more closely and more frequently. It is not a screening test for every painful joint. So please do not perform ANA as a first line panel test. I've already dealt with this. Do not perform biopsy until and unless it's a single joint. When you are suspecting a bleed or an infection inside, it's not diagnostic for GIA. Now, amongst all the GIAs, I'm not going to deal with any other GIA except systemic GIA because you will realize in the end that this is the most common mimicker. I'm calling it a mimicker of infection and all because now we see many patients coming with the diagnosis of SGIA and they are not SGIA, they are infection or Kawasaki or malignancy. So it is not these other conditions which are a mimicker of SGIA, it's SGIA which is a mimicker of these diseases. So why is SGIA called the giraffe? Because all other GIAs need 6 weeks to diagnose as a criteria. Systemic GIA, you could have only 2 weeks of fever with the symptoms that I'll come to soon, and maybe you could give them a diagnosis of SGIA, but only after exclusion, because GIA is a disease of pattern recognition and exclusion. It is not a disease of first diagnosis.
Kindly mute yourself, please.
Okay, so what I want to emphasize here is do not diagnose GIA till you've ruled out infections, malignancies, and look at these examples. This is the presentation of SGIA generally. Quotidian fever. You can predict when the next fever bout will be. Joints and a typical rash, which is known as an evanescent rash. Rash comes with fever, goes away with fever. Comes with fever, goes away fever. This would be a telltale sign. Still, it would not be SGIA till you rule out other things. Please mind that. For example, this is a 3-year-old male child presented with similar picture like SGIA, quotidian fever, rash was there, joints was there, and this was the typical blood findings. Leukocytosis, which is neutrophilic, inflammatory platelets, high ESR, CRP, ferritin, okay, nominally high. We diagnosed as SGIA, simple and sweet. What happened after that? After that, after a few days of treatment, this child developed high-grade continuous fever. It was no more quotidian. What would you think of? Similar finding, only the fever pattern changed. And when we did the tests, what did we find? Hemoglobin drops, total counts drops, platelet drops, ESR drops. Looking at this ESR, someone would be very happy. Looking at all this, is the child improving or is the child deteriorating? What is happening to the SGIA here? What do we find here? Ferritin, gone above 8,000. This is just to emphasize the previous slide. This is how important a simple CBC and primary level test can lead you to. Here we were dealing with macrophage activation syndrome, which is again like an emergency in rheumatology. And a similar child presented with us, very similar history to SGIA, was being treated as SGIA for 6 months. But when she came back to us, this was the blood picture. What did we hear? The ferritin was normal, but what was the most striking thing here was this. What do we see here in a 9-year-old child? You do not expect lymphocytes to go to 87%. There is a reversal. This and thrombocytopenia was our only clue, and this was not in one CBC in that child. This was happening in at least 3 to 4 CBCs in that child, and child was being treated was for systemic GIA, and the child turned out to be leukemia. And that is why again and again you're hearing me say, do not diagnose rheumatology until and unless you've ruled out malignancy and infection. Malignancy is something you cannot miss. And so one more, do not start steroids even if you have fever for a month. Do not be in a hurry to give some relief to the patient, because one shot of steroid and this whole picture would go haywire and you will miss out leukemia in the process. These 4 diseases together look like SGIA. They are all mimics. And that is why I brought SGIA case today, and I'm not going to deal with other GIAs, because these are the things, these 5 things you have to again and again look, investigate, do not start steroids till you come to a proper diagnosis and refer if not. One slide each on the flare. We've looked at arthritis, we've looked at the fever with SGIA can present with. Coming to R, which is rash, the flare that we saw earlier. These are the different types of rashes that we could get, and this is what it looks like. Palpable purpura which you can palpate, a very telltale sign. This is chilblain, where in cold, this child's toes used to become like that, gangrenous toe. Typical rash of autoinflammatory disease, which looks it's like macular, but it's erythematous patches all over the body. A single lesion like this on the legs, like erythema nodosum. The scope is too less now to go into all types, but I want all of you to go back with a pictorial memory of what could present as rheumatological disease. This child was being treated for a long time and was getting operated for an ulcerative lesion. Turned out to be Papadis syndrome. Not important to know the diagnosis, but this is pyoderma gangrenosa. Such a huge lesion which is not getting okay. Think rheumatological cause. This is the telltale rash, malar butterfly rash of lupus. Child walks into your clinic without any history. You know you're dealing with leukopenia, with maybe lupus and other things. If you do like ANA, look at proteinuria, find cytopenia, you might be dealing with a lupus. Next slide. A child who limps and comes to your clinic. It's a symptom. It's not a diagnosis. It is not GIA. It could have many diagnoses. GIA would again be your last diagnosis here. Rule out infection. Again, rule out malignancy. I've forgotten to add here, but we see a lot of sickle cell diseases coming like that with the limb because of avascular necrosis. We see hematological conditions coming like this. So we need a limping child. A limp is a symptom. It's not a diagnosis, and growing pains do not cause limp. A limping child with pain in the leg, we do not diagnose growing pains. We have children coming to us we have 9-year-old child coming with us with growing pain, turned out to be sickle. And that is why I thought it was important to put this slide here. I'm going to rush through. I don't know if I've crossed my time. Dr. Rujul, you will remind me. This
No,
will
ma'am,
give,
we have about 5 minutes.
okay. This would give you an idea of how diseases can involve, and when you have to become alert and when you have to refer. This was a 14-year-old child. First week came with only fever during COVID times, where she was being treated for COVID. Week 2 developed something in otorrhea and turned out to be mastoiditis, was being treated for mastoiditis. Slowly developed in 1.5 months chondritis and epistaxis. Again, child went to many doctors and many ENT doctors who kept on treating for an upper respiratory tract problem. And then child was referred to us for episcleritis, redness of both the eyes, and arthritis. It is only by 9th week did the entire spectrum come to us, and it became clear. But I feel if a child on week 3 to 4, when she had visited at least 15 doctors, some doctors should have thought that why is this same child getting mastoiditis? Why is this same child going and getting something in the nasal bones? Why is this child getting eyes and now joints? Only at this joint stage we think rheumatology. But all rheumatological conditions may not even have joints. This is what it looked like. Bilateral episcleritis. It turned out to be vasculitis. So if you have a skin, you have urine, proteinuria. This child also had proteinuria. You have higher BP, you have abdominal complaints, you have headaches, you have strokes. So basically many systems involved. With rash, think vasculitis. This could be evolving. It could evolve over 3-4 months. But a child who comes back to you the third time with similar problems, not getting okay, think again. How many of us have again and again changed antibiotics and given to patients? Why? Antibiotic resistance is not as common. There are many people in waiting room. It's not very common, the antibiotic resistance. Do not change to a third antibiotic. Go back to basics and think, are you dealing with something else? These are the common symptoms. Scrotal edema. We recently had a child referred for scrotal edema. When we looked back, child turned out to be HSP, Hinox-Schondin purpura. It was a vasculitis. Basically, HSP, which all of us I'm sure have seen, is a vasculitic thing. So it can involve any of the symptoms here. One slide again, only to give you a pictorial overview of what autoinflammatory diseases can look like. A clue to you would be early onset, maybe infantile stage, rashes early onset, consanguinity or endogamy, recurrent fevers. You could, the patient will tell you कि हम कुछ दवाई दें या नहीं दें, वो ठीक भी हो जाता है और फिर से भी आ जाता है. CNS symptoms, basal ganglia calcification, focal calcifications. You're not dealing with anything but autoinflammatory disease. Go back to history and maybe you could save some child's life also. These are the different presentations with autoinflammatory diseases come with. These are newer kids on the block. Very high chances that we miss it. But only if you're sensitized would you think of it. And that is why individual slides I've put together just to give you an idea of what to look for if your child is not getting okay. These KD, Kawasaki disease, you cannot miss. You cannot miss. A child who comes like that, mucositis-like picture, BCG activation, rash, very early sign of perianal excoriation. This comes within a week. Others might come later. These two are later. After you've missed the boat, this will come. And this will give you a retrospective diagnosis. Kawasaki diseases are on a surge post-COVID. We've not seen so many Kawasaki's before COVID as we see now. And looking at these pictures, I'm sure many of you are thinking, oh yes, I've seen it. BCG scarring, BCG mark has to be specially looked for. Patient will not complain. Perianal excoriation, you have to look for. Patient will not complain. None of us can afford to miss Kawasaki disease who are sitting in this forum today. because we would have done a grave injury to some patient here. This is the criteria: high-grade fever, conjunctivitis with bulbar saving. You will see a white trim around the cornea and then conjunctivitis-like lesion and the pictures that I've shown just now, which will lead you to a diagnosis. And towards the end of the presentation, I will play a video. I want all of you to think in your mind what you're dealing with. Sorry. First thing, too painful for JIA. Not able to stand. This second picture is 3 days post treatment. Can anyone here think what treatment must have been given? In 3 days, which condition will improve like that, which can present with a painful joint condition? This was scurvy. And so this is my last slide. Go back with the message. Think flare, fever, limp, arthritis, rash, eye, extra-articular, which is coming again and again, not getting treated, not getting explained, running in the family, early onset, consanguineous or endogamous with these other things. Then think rheumatology. Learn to recognize, treat, and refer timely. Thank you.
Thank you, Dr. Archana. Any questions for ma'am? You can ask or even type in the chat box. In the chat box, ma'am, we don't have any questions. Anyone wants to ask any questions, any doubts? Ma'am, I'll let you know if anything. Thank you
Sure.
so much, ma'am.
Thank you.
Our next speaker is Dr. Bharat Parmar, sir. Sir will be talking about fever in children. Dr. Bharat Parmar is a senior pediatrician practicing in Mumbai for past 39 years, and he's attached to SRCC Children's Hospital. Sir is also very socially active as the All India President of Giant Doctors Federation, and he's been the past district governor of Lions Club International Mumbai district. Sir will be talking about fever in children. Dr. Parmar.
Thank you, Ruzal, for a nice introduction. Thank you.
Welcome, sir.
Can you hear me?
Yes, sir.
And thank you, SRCC Hospital, for providing this platform to me to reach out to all my colleagues, general practitioner. This is a very common topic. Day to day we see fever. And today I'm going to talk about fever in pediatric age group in children.
So you can share your
I'm
presentation. Yes, sir.
sharing.
Yes, sir.
Just 1 minute. Can you see the presentation?
Yes, sir, we can see it.
Okay. Thank you, everybody. Sorry for delay. So what is fever? Actually, fever is not a disease, but it's a symptom, the natural response of the body to disease. So any disease can manifest with a fever, which we discussed in the due course of time. It is the elevation of body temperature due to hypothalamic set point increase. The pre-optic area in the hypothalamus which controls the temperature. And the rectal temperature more than 38 degrees centigrade, 100.4, defines the fever. So how to measure temperature? It's very important in pediatric age group temperature to be measured. So ideally the rectal is the most accurate in the infants. Oral is also suitable for older children, and the tympanic rapid but technique dependent, and the axillary, which is the commonly used screening method. The rectal temperature of 38 degree, 100.4 or higher is considered as fever. It is oral temperature is 0.5 degree lower than the rectal, and the axillary temperature further lower than 0.5 degree by the rectal temperature. So if the rectal temperature is 38, then the axillary temperature 37.2 is normal, around 99.5, 99 degree Fahrenheit, or 100 degrees for the rectal temperature. What is important is the core temperature. The measurement can be done at rectum, tympanic membrane, or the lower esophagus. So above 41.5 degree, that is 107 degrees, is called hyperparexia, which can lead to irreversible organ damage. Now, classification of fever. Hypothermia is less than 35 degree, that is 95 degree Fahrenheit. Subnormal 95 to 97. Normal is 98 to 99, to be precise 98.6 degree Fahrenheit in the axilla. So mild fever is 99 to 100, moderate is 100 to 103, high fever is 103 to 105, and hyperparexia is more than 105. Now, what is the mechanism of fever? The phagocytic cells in the blood and tissue releases interleukin-1 and other cytokines, which acts on the anterior hypothalamus, that is the preoptic area, and which causes an abrupt increase in the prostaglandin synthesis, PGE2, that causes elevation of set point of thermoregulatory center and the body temperature perceived as too low with reference to the new set point, and augmented heat production by increased metabolic rate, increased muscle tone and activity, along with decreased heat loss through diminished skin perfusion. So there's a rise in body temperature to equilibrate with the elevated set point. So there are release of endogenous pyrogens, exogenous pyrogens, and pyrogens stimulates the synthesis of prostaglandin. So that's why we have to give prostaglandin inhibitor drugs to reduce the temperature. Prostaglandin E2 is the ultimate endogenous pyrogen. It resets the temperature of the hypothalamus. So this is in brief about the mechanism of fever. Now, is fever is bad or fever is good? Fever is good also and fever is bad also, but advantage of the fever is bacterial survival is not possible at higher temperature. So the bacteria, in the contrary, the bacteria gets destroyed when the body temperature is higher. So it should not get panic. You have to always console the parents and tell them that don't worry, if fever will come down, it's sometimes good for the child also. It decreases iron and increases TIBC, which is unfavorable to pathogen growth. So the bacteria does not grow at high temperature, and increases polymorphonuclear lymphocytes activity on moderate higher temperature. Now, disadvantage, it is very uneasiness to child, parents get panic. Then febrile seizure is the most panic reaction occurs in children, which is common from 6 months to 3 years or up to 5 years. And it increases metabolic demand, increases oxygen consumption, and increases the carbon dioxide production. So child becomes very weak, lethargic, and dull, and parents get panic. So these are the disadvantages of fever. Now, there are different types of fever, and according to types of fever, we can diagnose or we can say clinically this could be this. Like continuous fever, the temperature continuously remains above normal with daily fluctuation of less than 1 degree centigrade. This is more common in viral pneumonia or typhus. Then remittent fever, the temperature continuously remains above normal with daily fluctuation of more or less than 1 degree or equal to 1 degree centigrade. That is more common in sepsis, tuberculosis, rheumatic fever. Then the intermittent fever, temperature remains above normal only for a certain period, later returning back to normal. Pleuritis, sepsis. Then biphasic fever, the fever that breaks and returns twice a day. Yellow fever, dengue, malaria, typhoid, leptospirosis. Undulant fever, temperature continuously remains above normal with daily fluctuation more than 1 degree centigrade, brucellosis. Then relapsing fever or recurrent fever, the days of fever followed by an afebrile period of several days. Then again relapse into additional days of fever, usually after 14 to 21 days. Pale abstinent fever, fever lasting 1 to 2 weeks, followed by 1 to 2 weeks of an afebrile period. And periodic fever that occurs over months or years, associated with absence of infection or malignancy. Now, clinical presentation of fever. So we'll discuss this fever in 4 headings: fever with rash, fever with localized signs, fever without localized signs, prolonged fever, and fever of unknown origin. Now, what is fever with rash? Commonly what we see, different types of rashes what we can get. maculopapular rash, which is more common in measles, rubella, dengue, roseola infantum. The vesicular rash, more commonly seen in chickenpox, varicella zoster, herpes simplex, and enterovirus. Purpuric or petechial rash, dengue, chikungunya, meningococcus septicemia. Urticarial rash, Coxsackie virus, hand, foot, mouth, Yersinia, and Borrelia. And nodular rashes in tuberculosis. Now, relationship of rash to the fever. Simple mnemonic that first day of fever, if you see the rash, then more likely it is chickenpox, typical centripetal rash, vesicular rash, pleomorphic rash. Then second day of fever, scarlet fever. Third day of fever, smallpox, we don't see now. Fourth day of fever, measles. Fifth day of fever, typhus. Sixth day of fever, dengue. And seventh day of fever, typhoid. So from the days of rash appearance, you can clinically, or you can say this could be this. We'll discuss few of the common rash presentation of fever. Nowadays, we see lots of, now this is endemic now in our, epidemic. Almost every child we see in OPD, daily 2 to 3 child we are seeing nowadays for measles. It is acute onset, 3 C's, commonly cough, coryza, conjunctivitis. They have severe conjunctival condition, coplic spots in the oral mucosa. Before the rash comes on the body, there you see rash on the oral mucosa. It's a small sago grain type of rash, shiny rashes. If you see with that spatula on the palate, you can see, or in the buccal mucosa, you can see. The maculopapular rash comes on the 4th day of fever, begins on face, generally behind the nape of the neck or behind the ear, and then spreads downward to trunk and the limbs. As the rash goes down, the fever goes down. The treatment is symptomatic cure. The most important is to give vitamin A to prevent eye damage because it can cause severe keratoconjunctivitis and blindness. So vitamin A prophylaxis is very important to all these children. About 2 lakhs units of vitamin A given to each child suffering from measles. You get tablet forms, or you can get liquid forms, or you can get injection forms in the market. Nowadays, I think only tablet is available by Abbott company, vitamin A tablet, which can be given orally. If you have access to BMC, BMC gives free of charge vitamin A. Now, chickenpox, see the rashes, varicella, it's more common in the central part of the body. Pleomorphic rashes, you can see different types of rashes. You can see low-grade fever with a vesicular rash on first day, lesions in different stages. So in one sitting, you will see vesicles, pustules, small nodules, everything you will see. So pleomorphic rashes, centripetal distribution, highly contagious viral infection. The treatment is maintaining hygiene, symptomatic care, and if started early, within 1 or 2 days, then the antiviral acyclovir helps. Generally, after 4 to 5 days of rashes, the antiviral does not help. You have to start within 48 hours. Then infectious mononucleosis. If you see the slide, you can see it looks like a follicular tonsillitis, but it's very commonly seen in infectious mononucleosis or Epstein-Barr virus. And the diagnostic will be when you give amoxicillin or ampicillin, these children will come out with the rashes. So that is classical of infectious mononucleosis, fever, pharyngitis, lymphadenopathy. Sometimes lymphadenopathy can be so severe and so big lymph node that it can be diagnosed as leukemia. I've seen recently one child who has been told that he got leukemia and turned out to be infectious mononucleosis. They have a splenomegaly, which is very soft spleen, and that's why these children requires rest, because if they have any trauma, the spleen can rupture. Maculopapular rash, and treatment is symptomatic care, antiviral, steroid only in airway complication, otherwise not indicated. You have to follow these children regularly for autoimmune hemolytic anemia, and they are prone for Burkitt's lymphoma. So regularly we have to do CBC and SGPT and hemoglobin every 3 months and follow these children regularly. Now, dengue, which is very common, dengue hemorrhagic fever or dengue shock syndrome, high-grade fever with retroorbital pain and myalgia, severe pain. Maculopapular rash generally develops from 5th or 6th day of fever, and they are with thrombocytopenia. Herpes simplex, root vesicles typically seen on the angle of the mouth at the erythematous base, painful mucocutaneous lesions. Fever is primary infection. Treatment is acyclovir, and hand, foot, mouth disease commonly seen nowadays. Fever and malaise, sore throat, vesicles on buccal mucosa, maculopapular or vesicular rash on hands and feet, and thrombocytopenia. Treatment is symptomatic. And rheumatic disease nowadays we don't see much because of the vaccine and good care. But you can get typical erythema marginatum, you can see, or red vesicles you can see here. So treatment again, if diagnosed earlier, antibiotics, steroids, aspirin or NSAIDs. Now, drug-induced non-infectious fever with rash. So sometimes the drugs can cause rash, and these are commonly what we see: Stevens-Johnson syndrome, toxic epidermal necrolysis, Dress syndrome, drug reaction with eosinophilia, AGEP, acute generalized exanthematous pustulosis, and lichen simplex chronicus. The most common what we see is Stevens-Johnson syndrome. You can see in the picture the drug which commonly causes are penicillin, tetracycline, phenytoin, carbamazepine, barbiturates, and NSAIDs. The child will present with fever, malaise, headache, ulceration of lips, and widespread mucocutaneous is the commonest cause. Diagnostic feature: painful erythema, palms and soles, and the purpuricus evolves in blister within 12 hours. Now, Drace syndrome, drug reaction with eosinophilia and systemic symptoms. The causative drugs are phenytoin, carbamazepine, all AEDs, anti-epileptic drugs, sulfonamide, sulfadepsone, minocycline, allopurinol, NSAIDs. Again, they also present with fever, lymphadenopathy, macular erythema on face, progressing to papillary hepatomegaly and facial edema. So these are two common things. Then AGEP and lichen simplex. Now, collagen vascular disease, I think Archana, my previous colleague, already dealt in detail about systemic juvenile idiopathic arthritis, SLE, Kawasaki disease. She talked in detail about hinoxalumin purpura, so I will not go and at the cost of repetition, but this could be one of the cause of the fever, especially prolonged fever or PAO, so that should be kept in mind. I think she already dealt so nicely in detail, so I will not go again. I will skip all the slides of Kawasaki, juvenile dermatomyositis, SJIA, hinoxalumin purpura. Okay, now fever with localized signs. So typically, the localization you can get with the fever, like the viral uveitis is the most common, otitis media, tonsillitis, bronchitis, bronchiolitis, pneumonia, laryngitis. Now GI infection, gastroenteritis, appendicitis, hepatitis, CNS infection, meningitis, encephalitis, others, Kala Azar, herpetic stomatitis. Now prolonged fever, fever lasting more than 7 to 10 days, which requires evaluation for chronic infections and consider malignancy or autoimmune disease. Any prolonged fever, malignancy or autoimmune disease to be considered. Now, causes of prolonged fever: sinusitis, infective endocarditis, occult abscesses, very common, tuberculosis, brucellosis, very common in our country, tuberculosis, enteric fever, osteomyelitis, toxoplasmosis, leukemia, and sarcoidosis. Now, fever without localized signs, when you cannot localize the fever acute onset. Now, if it is of acute onset and short duration of less than 1 week and no any signs or symptoms localized in the organ system, will divide into 3 groups: 0 to 1 month, 1 to 3 months, and 3 to 36 months, because we are more worried about small children and how we have to deal with them. So rectal temperature is a gold standard but not advisable. Axillary temperature should be preferred by digital thermometer. For newborn or young infant with fever, first admit the child and control the temperature of room. Adequate hydration, increase breastfeeding. If persistence of fever after this, suspect severe bacterial infection. Etiology most common in newborn: H. influenza, Streptococcus pneumonia, Klebsiella, Staphylococcus aureus, Listeria monocytogenes, or herpes simplex virus. Investigation: we first line investigation we do CBC with band form cell, malaria parasite, urine routine culture, blood culture, chest X-ray, LP and CSF examination for lethargic. If child is very lethargic or fontanelle is boggy, if they are vomiting, irritable, then we consider LP. Management: start with empirical antibiotic. There's most of the children will be indoor, so not interested of general practitioner, but this just to touch upon, we have to admit this child, any child who is less than 1 month having high fever, irritable, we have to admit and start investigation and start with an empirical antibiotic. And then we will modify as per the report, cultures and the CBC report. Now, most common cause in 1 to 3 months. Generally, self-limited seasonal viral illness are more common. Then severe bacterial infection can be seen: otitis media, pneumonia, skin and soft tissue infection, pneumocolitis, UTI. Etiology group with Streptococcus, E. coli, Streptococcus pneumonia, H. influenza, Neisseria meningitis, meningococcus, enterococci, and pyelonephritis is the most common bacterial infection. Investigation: basic investigation, CBC, blood culture, urine routine culture, lumbar puncture, chest radiogram. Management: if the child ill-looking children, then immediately hospitalization. Empirical antibiotics after the hospitalization, and after getting the investigation, we will change the antibiotic. Ampicillin plus cefotaxime is the first line of antibiotic we start. Then vancomycin only in suspicion of meningitis or resistant pneumonia, or antibiotic modify after culture report. Now, well-looking children, just observe the child and follow up after 24 hours with investigation. Prior to start antibiotic in deterioration, look for lumbar puncture. Don't start antibiotic empirically. Now, 3 to 36 months. This is about smaller children. Now, bigger children, the common again is viral infection. Most common is viral infection. Then severe bacterial infection seen Streptococcus pneumonia, Neisseria, H. influenza. Commonly, we see otitis media, sinusitis, enteritis, gastroenteritis, urinary tract infection, osteomyelitis, and meningitis. Now, management: if temperature more than 39 degrees centigrade and TLC more than 15,000, obtain blood culture and start empirical antibiotic. If temperature 38 to 39, reassure and return. If fever more than 39 or become sick, then again do all the investigation, admit the child and start antibiotic. Now, fever of unknown origin, which is the most common problem we face in practice also. It is the uncommon presentation of the common disease. Now, fever more than 38 degrees centigrade, rectal temperature by healthcare personnel more than 3 weeks on OPD basis or less than 7 days in IPD basis, without a clear focus on infection after a complete physical examination and basic investigation. If you can't find any focus on infection in IPD patient after 7 days or more than 3 weeks on OPD basis, then you term this as a PUO. Then you have to do more investigation. Now, IPD patient will always consider nosocomial or healthcare associated fever of unknown origin, neutropenic FEO, HIV related FEO, or fever without localizing sign. Nosocomial or healthcare associated FEO in hospital children who received the acute care in hospital, who was afebrile at admission, but now fever of 38 degrees centigrade or more on several occasions for at least 1 week. Neutropenic FEO, multiple reading of fever less than 38 degrees and more than 38 degrees centigrade, and absolute neutrophil count less than 500, severe neutropenia. And after 3 days of investigation, after 48 hours incubation and culture, in confirmed case of HIV infection for HIV related FEO, multiple spikes of fever more than 38 degrees, time period more than 3 weeks on OPD basis or less than 1 week on IPD basis. So, etiology of FEO. Commonest is infection. Connective tissue and autoimmune disorder, already Archana has dealt in details. Hypersensitive disorders, malignancies, granulomatous disorders, familial and hereditary disorders, hematologic disorders, endocrine disorders, and miscellaneous causes. Now, infection. The commonest infection in our country after acute infection is tuberculosis and typhoid, which you see commonly in your day-to-day practice, and others are paratyphoid, brucellosis, listeriosis, meningococcemia, arsinosis, campylobacter, relapsing fever, which are not commonly seen. But these two, tuberculosis, typhoid, always keep in mind. Viral infections, mononucleosis, I already told you. HIV, nowadays we don't see much. Hepatitis and cytomegalovirus. Hepatitis, yes, we see a lot of cases. CMV, not much. Parasitic malaria, yes, rampant we see. Cholera, not much. Amoebic abscess, yes, we see a lot of cases of amoebic abscess or occult abscess. Anywhere, if the fever you can't diagnose, then this could be occult abscess, either intra-abdominal, psoas abscess, brain abscess, liver abscess, lung abscess, hepatic amoebiasis, giardiasis, toxoplasmosis, trypanosomiasis, and visceral larva migraine. They're not so common. Now, rickettsia, scrub typhus, Q fever, Rocky Mountain spotted fever, fungal disseminated candidiasis, histoplasmosis, aspergillosis, especially immunodeficient or hospitalized child, we will see all this, or prolonged use of antibiotics, blastomycosis, children with leukemias on chemotherapy, disseminated coccidioidomycosis, and cryptococcosis. Connective tissue, already she has discussed in detail. SLE, juvenile idiopathic arthritis, rheumatic fever, dermatomyositis, autoimmune thyroiditis, polyarthritis nodosa, chronic active hepatitis, hypersensitivity disorder, drug fever, serum sickness, hypersensitive pneumonia, and Webster Christian disease. Malignancies, very common: Hodgkin's disease, leukemia, lymphoma, inflammatory pseudotumors, pheochromocytoma, neuroblastoma, and Wilms tumor, and the granulomatous disorder, sarcoidosis, granulomatous hepatitis, inflammatory bowel disease. Familial and hereditary syndromes, familial dysautonomia, familial Mediterranean fever, anhydrotic ectodermal dysplasias. These are very rare causes. Ichthyosis, just to complete the list, I'm reading out the name. And hematologic causes, hemophagocytic lymphohistiocytic syndrome, HLH. Nowadays, we see a lot of cases, especially even secondary HLH. Primary HLH, different secondary HLH. Any severe infection can cause disturbance in macrophage system, and they have secondary HLH. Cyclic neutropenia, immunodeficiency states, Kikuchi Fujimoto disease comes typically present with multiple lymph nodes, and Castleman disease. Endocrine causes Addison disease, crisis, thyrotoxicosis, hypothalamic central fever, and diabetes insipidus because of dehydration. The miscellaneous causes factitious fever, infantile cortical hyperostosis, pancreatitis, drug fever, poisonings, thrombophlebitis, and pulmonary embolism. So this is an exhaustive list of FUO, fever of unknown origin. How to approach? Unless the child is acutely ill, the evaluation for FUO, fever of unknown origin, or PO, should be done on outpatient basis. If outpatient evaluation fails to disclose a cause for the fever, inpatient evaluation provides an opportunity to review the detailed history, physical examination, investigation, reports, and keep the child under close observation with an ongoing assessment to establish the cause of fever. History is very important, clinical examination, and the laboratory test. Now, characteristic of fever: onset, intensity, duration, frequency, and pattern, which we already discussed. Different types of fever. Whether fever is intermittent, high spikes and rapid effervescence, remittent, sustained fever with little or no fluctuation, pale abstinent fever, fever chills and rigor, relapsing fever. Now, intermittent with high spike and rapid fever is usually seen in pyogenic infection, tuberculosis, lymphoma, and connective tissue disorder. Remittent fever, generally viral infection, bacterial infection, sarcoidosis, lymphomas, already seen. Now, most important, sustained fever with little or no fluctuation, but seen in intermittent if antipyretic agent administered. Enteric fever, most common, pale abstinent fever, Hodgkin's disease, fever chills and rigor, malaria, UTI, abscess, occult abscesses, and nosocomial infection. Now, relapsing fever, again malaria, rat bite, lymphomas, borrelia infection. Now, site of temperature, localizing symptoms of fever, whether there is any recent exposure of vaccination, animal insect bite, recent blood transfusion, family history of fever, past history of COVID, because post-COVID we have seen a lot of cases of MISC, multisystemic inflammatory syndrome, or TB, UTI, congenital heart disease, any travel history in specific disease, endemic areas, history of underlying chronic illness, medication history, history of cyclic cause of fever, cyclic neutropenia, hyperimmunoglobulin D disease, or CNS disease of temperature regulation, history of tick bite, Rocky Mountain spot fever, and multi-system inflammatory syndrome, past history of COVID. Examination, look for skin fundus from head to toe. You have to examine in detail any skin changes, look at the fundus, throat, lymph nodes, genitalia, sinuses, detailed eye inspection, cornea, retina, very important. When we all can diagnose connective tissue disorder by eye examination, whether there are changes of uveitis or orbit, uveal tract, vascular, metabolic, malignant disorder, fever without sweating, anhydrotic ectodermal dysplasia, fever without malaise, factious fever, examine rectal, genetic, and pelvic examination. Now, laboratory tests, commonly what we do, CBC, TLC with DLC, ESR, peripheral blood culture, urine stool examination, LFT, RFT, serum electrolytes. ESR more than 30 suggestive of inflammation. ESR and CRP are prognostic markers and need for monitoring purpose. Sterile pyuria suggestive of Kawasaki disease or genital urinary TB, hypernatremia, diabetes insipidus, high liver enzymes, viral infection, hepatitis, bone marrow for leukemia, lymphoma, histiocytic and hemophagocytic disorder, serum ANA for rheumatic disease, hypogammaglobulinemia suggestive of immunodeficiency, hypergammaglobulinemia, chronic infection, autoimmune disease, PCR of various infections you can do. Now, CBC itself can give you a lot of clues. Now, if you see a CBC and shows low hemoglobin, that means the child has got chronic infection, or it could be acute hemolysis. Like in malaria, what you see, acute hemolysis, the hemoglobin drops down, or because of chronic malnutrition, the hemoglobin low. Malaria, infective endocarditis, irritable bowel disease, SLA, and TB. Thrombocytosis, suggestive of inflammation or Kawasaki disease. Now, TLC more than 10,000 always indicates some bacterial infection. Non-segmented polymorphic leukocyte, more than 500. Serious bacterial infection. Eosinophilia means parasitic, fungal, allergic, or immune deficiency state like eosinopenia, could be typhoid fever, immature band cells, leukemia, activated lymphocytes, viral infection, atypical lymphocyte typically seen in Epstein-Barr virus, infectious mononucleosis. So sometimes pathologists can tell you diagnosis that I can see atypical lymphocytes, very typical of infectious mononucleosis. Then imaging, basic imaging, X-ray, chest, sinuses, mastoid, abdomen, sonography, then CT scan, MRI, PET scan, immunoscintigraphy, lymphangiography, biopsies, bone marrow, liver, lymph node. Treatment, empirical antibiotics only in neutropenic child, otherwise no empirical antibiotics before diagnosis because of masking diagnosis. So after the course, in some conditions like infective endocarditis, meningitis, osteomyelitis, we have to alter the course after seeing the culture reports and may require long-term or 2 to 6 weeks of antibiotic. Empirical antibiotic also interferes with isolation of microorganisms in blood culture. Now, tips for parents to manage fever. So this is discussed. We all discuss all the causes. It was difficult to cover and discuss each disease in detail and about management, but we can always have separate class for that. But what as a family physician we will advise parents to how to manage fever. That is very important, and you have to counsel the parents that don't get panic. The fluid intake is very important. That ensure adequate fluid intake as children lose more fluid during fever. So it's very important to maintain hydration. Feeding small sips of water during episodes of fever. The child may be allowed to eat whatever she wants. Generally, there should not be any food restriction. If child likes something, give that. Activity except for running around for long, children can play all day long despite the fever. Indoor activities allowed, outdoor activities should not be allowed. Now, tips for parent again: going out, avoid going to play groups, nursery, kindergarten to avoid infecting other children. Clothing, loose, comfortable clothing in accordance to the surrounding climate. Avoid overdressing the child or dressing too warm as the body does not cool off easily. Very important. Now, bathing. Most of the parents are not in favor of giving bath to child, but it helps to bring down the temperature. In young children less than 3 months, sponging using tepid water is preferred to avoid hypothermia. Cold water bath must be avoided as it can induce shivering. Instead, cooling the lower leg of the child with wet towels or lukewarm bath can be carried out to cool the outer body. Cool compress can also be applied. Now, warning sign to seek medical advice. So, what are the warning signs? Child younger than 3 months who is lethargic, irritable, and crying needs immediate attention, should be hospitalized and should be referred. Vomiting everything that has been fed or eaten. Headache. Acute headache is very, very, very because children don't usually complain of headache. Chronic headache we ignore, but acute headache and child comes, I have severe headache, doctor, I have fever. Definitely rule out meningitis or encephalitis. Neck stiffness, difficulty in breathing, abnormal body movements, temperature above 104 degree or persistent fever more than 5 days. Febrile seizures typically occur in children aged 6 months to 5 years. If there is family history or previous episode of febrile seizures, make the child more prone to it. Now, symptom management of fever. First and foremost, to bring down temperature, I already told you tepid sponging. Then second is to give oral drugs. Paracetamol is the most preferred drug to be given to the child for fever. 10 to 15 mg per kg per dose you have to give every 4 to 6 hours. So for 10 kg child, roughly in your practice, if you are using a paracetamol syrup containing 120 milligram per 5 ml, 5 to 6 ml every 4 to 6 hours you can give. If child is not taking orally, you can use suppository also, and you are getting suppository in the market of 70 milligrams, 170 milligram, and 250 milligram. So roughly a 5 kg child, you can use 70 milligram suppository. For about 10 to 12 kg, you can use 170, and 15 to 20, you can use 250 milligram suppository. Similarly, ibuprofen dose is around 5 to 10 mg, 7 mg for inflammation, 10 mg for fever. Every 8 hourly, 10 kg child, you have to give ibuprofen 5 ml every 8 hourly. To be used in children, it should not be used in children less than 6 months of age, above 6 months of age with caution, and especially in children with kidney disease or children with diarrhea and because of dehydration or chronic kidney disease, it should be avoided. And especially in dengue and low platelet counts, we are worried about that. Mefenamic acid can be used, but again, it has got side effects. So to be used with caution, 6 milligram per kg every 6 to 8 hours. So 10 kg child, mefenamic acid 100 milligram per 5 ml syrup, what you get, Meftal P, give 3 ml every 6 to 8 hours. And febrile seizure prophylaxis, with a history of febrile conversion, then you can give next episode. Clobazam syrup is available, tablets available. For 10 kg child, you give half tablet, or syrup you give 1 ml twice a day. Thank you. Any questions? Please be free to ask.
Thank you, sir. Any questions from the participants, from the audience? Sir, even in the chat box, there are no questions. There's someone who's asked for the payment for the credit point. No, there are no payment for the credit point. You need to register, and participation throughout the master class is needed for the MMC point. There is no payment. Coming to our next speaker is Dr. Behzad Bhandari. Dr. Behzad is a consultant in pediatrics at SRCC Children's Hospital. Dr. Behzad is in charge of our emergency services, and he is the one who's taking care of all the pediatric emergencies in the last few years at SRCC Children's Hospital. Welcome, Dr. Behzad.
Thank you, Dr. Rujul. Am I audible?
Yes, you're audible.
Okay, so I'll try to make my topic as brief, simple as possible. We are going to be talking about childhood injuries right now. Commonly seen injuries that we face in a pediatric emergency or a pediatric ER. These would include cuts, wounds or lacerations, dislocations and fractures, head injuries, burns, animal bites, drowning, foreign bodies which are either ingested or lodged in other parts of the body, and then we have many others. I will just be briefly going over all these injuries, which will be helpful to both young pediatricians and general practitioners who first see these patients in their OPD. Now, there are three phases of injury prevention. First is primary prevention, where we prevent the new injuries. Secondary prevention is reducing the severity of an already existing injury. And tertiary is when we decrease the frequency and severity of disability after the injury has occurred. General measures of injury management always start with your ABCDEs, that is your airway, breathing, circulation, disability, and exposure. Then personal protection and infection control is a must. Use of gloves, mask, wound cleaning, use of antisepsis. Management of the injury, which may include assessment, investigations like X-rays or CTs, imaging, medications, which may include pain management, antibiotics. And since we are dealing with pediatric patients, supportive measures are equally important. Counseling of the parents, counseling of children, providing distractions, and helping them out overall is also important for managing these injuries. Starting with cuts, wounds, and lacerations. Now, these are the most commonly faced injuries that we see in a pediatric emergency. Most common are upper and lower limb abrasions and wounds, which are seen in toddlers or children who run around and play. It's mostly due to falls, accidents. Example is you can see in the picture here on the left-hand side, bruising, simple bruises and more severe ones lower down. Then lacerations on the scalp and face are secondly most common seen in pediatric ER. They are more common on the scalp and face because of the proximity of the bone and the skin. And examples are here. These are from cases seen in our hospital itself. And 99% of these do require suturing to close up. Fingers and toes being crushed with or without the presence of a fracture or with or without the presence of involvement of nail bed is another common injury seen because children have the habit of putting their fingers in between car windows or car doors or home windows and home doors. And it's another common injury that we see on a regular basis. Here is the X-ray of a child whose finger came in a car door. Usually, these injuries end up having just soft tissue damage, but if there is significant swelling, bruising, and pain, we advise getting an X-ray done, preferably in two views, so that we can rule out small minor fractures. And in many cases, we do find a fracture of the tip of the finger. Management of these kind of injuries is pressure application is the first thing that one can do. It is something that you can do at home or you can do in your OPD clinic. Elevation of the limb, application of a tourniquet, and followed by a dressing or suturing. Wound cleaning is very important, disinfection, decontamination, and debridement. Finally, we come to wound closure, which may include steri strips, glue, staples, or sutures. and wound care, which may involve antibiotics, injection TT, and pain management. Now, coming practically, here we see there are different methods of closing the wound, application of pressure, raising of the limb, disinfecting and cleaning the wound, sutures and staples. Staples most commonly used on the scalp. On the bottom left-hand side, you will see a small cut above the person's left eye, and there are strips that have been put. These are steri strips. Now, steri strips can be used only for minor cuts in which just some skin approximation will help heal the wound. Deeper cuts where the skin is quite wide apart and the wound is large, steri strips will not work in such a case. Now, what we see in our ER is many parents, but obviously are scared of the word suturing, and they would always prefer to do some kind of conservative management. But if you see these kind of wounds that I have shown in the picture here, these do not get by just bandaging or just, steri strips, because skin approximation sometimes is difficult just with the help of steri strips and they come out very easily. So in such cases, suturing the wound is the only option available. In pediatric patients, now suturing is done in two methods. It can be done either under local anesthesia or it can be done under general anesthesia or sedation. Most big children who are cooperative and who are less anxious can get suturing done in the ER in a few hours as a matter of under local anesthesia, basically. And small children or children who are anxious and who tend to move a lot during the procedure preferably need sedation, for which they need to be fasting for at least 4 to 6 hours. Now, at the bottom, you will see something called derma bond. Derma bond is something like a high viscosity glue or a skin glue that some people can use. But here again, it depends on the kind of wound, how deep it is, and how much the skin approximation is. Now, besides closing the wound management does not end there. We always have to ask the immunization status of the child, and most likely if they have received vaccination recently which covers tetanus, then we do not need to repeatedly give a tetanus injection after each injury. Many people do advise their pediatric patients, to take a TT after each wound, which is not a correct practice. Ideally, if they have been vaccinated as per their schedule, most of the children are covered for tetanus. Besides this, pain management is something that many people tend to overlook and is of utmost importance during any injury. Depending on the kind of wound, use of antibiotics may also have to be considered. Now let's talk about dislocations. Most common dislocation seen in the pediatric age group, especially the toddlers, is the pulled elbow or the nursemaid's elbow. This most commonly happens because children try to, run away from their parents or their caregivers, and there is a jerk to the elbow or the hand by the caregiver. What happens is there is a dislocation of the radial head and there is pain on active or passive movement. Most children that come to the ER usually have their hand kept in one side and they will not use or move that arm. Any active or passive movement makes them cry and makes them, uncomfortable. Generally, for pulled elbow, no X-ray is needed. The diagnosis is usually clinical. But if there is a history of some kind of trauma, then it's always better to get an X-ray done. Reduction of pulled elbow can be done in the ER. It's a very quick procedure which involves supination and flexion and is usually should be done while you're talking to the child or while you're talking to the parents and examining the child. It happens in a matter of seconds. And the advantage of this is the improvement is also seen within few seconds and a few minutes. The one who does the procedure or the one who does the reduction will usually feel a click at the elbow joint, which is diagnostic that you have set the radial head back in its place. Some children may not start movement immediately, while some others do. So, best thing is once you've done the reduction, let the child play around or move around in the ER or in the play area if you have one in the hospital, and then observe them quietly from a distance. Most of them who were usually previously very irritable and very cranky will become less cranky. They'll start using the arm, which they were not doing previously. So that way, you know that things are fine. In certain cases where certain children are more sensitive to pain, simple paracetamol may be given just for a day, just 1 or 2 doses. Fractures. Most common pediatric fractures are supracondylar fracture of humerus, green stick fractures, or torus fractures. Now, green stick fractures is basically cortical breaks without complete through and through breaks. That is because that is a specialty of the pediatric bones. It's always important to check the skin. Is it an open fracture or closed fracture? Check for circulation. Check for any discoloration, nerve function, any issues with the sensation. Now, whenever you're suspecting a fracture, it's always better to get two views for any X-ray, a lateral, for example, and an AP view, because in certain views, the cracks or the breaks may not be visible. So it's always preferable to get two views to get a better idea. Treatment usually involves splints, casts, slings, K-wires, or sometimes internal fixators. Besides this, pain management is of utmost importance. Besides that, wound management, SOS antibiotics depending on the nature of the wound, and rest of the limb. Burns. Another common injury that we see in the pediatric ER are burns. Fortunately, most of our pediatric burn patients do not come with severe burns and are mostly accidental burns that occur due to some hot liquids falling on the child and are usually treatable on an OPD basis. But certain children who suffer severe burns or extensive burns may require IP admissions or may require a specific burns unit depending on the case. Now, when a burns patient comes to you, by just looking at it, you can gauge whether it's a first degree, second degree, third degree, or fourth degree. As mentioned in the slide, first degree is superficial. It affects only the epidermis and the skin is usually red and painful. There are no blisters in a first degree burn. In a second degree burn, or which we call partial thickness, it affects dermis and epidermis, and formation of blisters, if you see along with redness and swelling, you may call it a second degree burn. Third degree or a full thickness burn, all skin layers are affected. Nerves are usually destroyed, so pain is not that much. Such kind of burns usually require skin grafting and take months to heal. And finally, we have the fourth degree or the full thickness burns, deep full thickness, which may affect structures under the skin, like the muscles and the bones. Now, calculation of the burn surface area is a chart that all pediatric ERs or emergencies should keep. Now, why is calculating BSA very important for a burn patient? Because the burn surface area is different for an adult, different for an infant, and different for a child. I'll just pause for a minute while you'll have a look at the differences. Although the children are small, their head occupies a larger surface area compared to that of an adult of the entire body. Why is this calculation of burn surface area important? Because it directly impacts patient survival and things like fluid resuscitation, complications, referral and triage, and the kind of nutrition that they receive all depend on the burn surface area. Do note that management of burns involves all of the following. Firstly, your ABCs have to be managed, that is your airway, breathing, and circulation. Use of cool water immediately on the burns. Removal of any clothes that the child must be wearing. For simple wounds, silver ointment is very useful for application. But later on, bacti-grass dressing is a dressing that is needed on the burn area. Now, if you see down on the bottom left-hand side, the doctor is applying a bacti-grass dressing on the wound. We usually advise against gauze dressing or cotton dressings on burns because these tend to stick to the burn area or the raw area and may prevent healing. They also are not ventilated and they do not provide adequate air for cooling and drying of the wound. So if any dressing needs to be done for a superficial small burn, bacti-grass dressing is usually the best dressing to be done. Severe burns may also require collagen application, which is seen on the right bottom hand side of the screen. It is the best dressing that is done usually intra-op and needs anesthesia because these kind of burns are usually very painful. Further treatment may involve skin grafting in very severe or large surface area burns. Now, besides just managing the actual burn, fluid and electrolyte management is of utmost importance because large body surface area burns have significant loss of fluid, dyselectrolytemia, and need to be managed in a specific burns unit. Pain management needs to go on round the clock as these burns can be very painful. Use of antibiotics to prevent infection is also important. And do not forget nutrition because in certain cases of burns where the child is unable to take anything orally, uh, nutrition support has to be given parenterally or through an RT. Sometimes the airways are also compromised. In such cases, nutrition has to be given through other sources. Now let's talk about head injuries. In head injuries, utmost importance is assessment of sensorium. Now, head injuries is very commonly seen in the ER. Some of them are minor, children falling off from beds, having injuries while playing, things like that. But as a pediatrician or as a general practitioner, things that you need to focus on are assessment of sensorium, the GCS. Is the child alert? Is he able to verbalize? How is his pain management? Or is he unresponsive? Now, look for tense fontanelles in a child less than 18 months. Any non-frontal scalp hematoma needs attention. Any suspected open, depressed, or palpable skull fractures is something that should not be unattended. Signs of base of skull fracture may include periorbital ecchymosis or panda sign, battle sign. Hemotympanum is blood in the ear. CSF otorrhea leak, CSF rhinorrhea are commonly seen in severe fractures of the base of the skull. Look for any new focal neurological deficits after the injury. Presence of bruising, swelling, or a laceration more than 5 centimeters on the head, irrespective of the location, should raise your antenna that something is serious. Presence of persistent vomiting is also something that we are not happy with and is seen with severe head injuries. Here you are seeing on the left-hand side hemotympanum, bruising around the ears, and the battle sign of the raccoon eyes, which indicate a floor of the skull fracture, and the right, something like a simple bruise. Now, TBI or traumatic brain injury can be classified as mild or moderate to severe. In mild, GCS is usually 13 to 15. In such a case, you observe the child in hospital for a few hours if feasible, and you can send them home after explaining all the danger signs. You usually need to follow up after 24 to 48 hours because if any symptoms are to occur in such kind of a head injury, they usually occur within the first 48 hours. Anything doesn't happen within the first 2 days, then rest assured, most likely nothing will happen. In moderate to severe TBI, the GCS is usually 9 to 12 or 3 to 8, and such patients should be observed in the ICUs. Look for any features of raised ICP, vomiting, seizures, irregular breathing, bradycardia, hypotension, unequal pupils. Consider neuroprotection. Keep the head in a midline position at 30 degrees elevation. Maintain euglycemia, normothermia, euvolemia. Anti-seizure medications may be needed and anti-edema measures need to be implemented. Now, many people have a doubt of when and when not to do a CT scan in case of a head injuries. Minor head injuries where the child is active, there isn't multiple episodes of vomiting, he's not drowsy, and does not have any other complications or other signs of fractures or injuries on the head, may not need a CT scan. Not all head injuries need a CT scan. But if you see the child is very small, has bruising around the head, has swelling, is very lethargic, is not feeding, having multiple episodes of vomiting, then depending on the clinical condition, the physician may consider doing a CT scan. Talking about the most common bleeds that we see, that is the EDH versus the SDH, extradural hematoma versus subdural hematoma. Just to brief out, EDH or extradural hematoma is outside the dura mater, between the dura mater and the skull. SDH is between the dura mater and the brain or the arachnoid surface. EDH is mostly arterial, middle meningeal artery, and can cause rapid deterioration. SDH is usually venous, caused due to rupture of the bridging veins, and shows usually slower progressive symptoms. EDH is a high density biconvex lesion confined by skull sutures. SDH is usually a crescent shape and can spread wider in the brain. EDH involves what we call a lucid interval, where the child seems absolutely fine, followed by rapid decline. SDH may present acutely or subacutely. EDH mostly needs immediate surgical evacuation of the clot, and SDH may be managed conservatively or later surgical drainage via burr hole, depending on the size and pressure may be needed. Just to give you a brief pressure, if you see on the right, now usually kids with a severe traumatic brain injury, you would suspect either an EDH or an SDH. You get a CT scan done, and if you see this shape, the lemon shape, it's an extradural hematoma. And on the right, what you see is a subdural hematoma. So if you keep this image in mind, you'll have an idea what you're dealing with and what to expect. Drowning. Drowning is another very common cause of morbidity and mortality in children. Terms like near drowning, passive, and dry drowning are not used anymore. Most common cause is toddlers and adolescents due to lack of supervision, adventurous behavior, or use of intoxicating substances. Always remember, preventive strategies are more important than the post-drowning care. Looking after your young children, seeing that they don't run around the pool area, seeing that they're supervised. Then adults who are intoxicated should not be allowed near the pool area. All these things are preventive measures that should be used in the first place. Now, the main pathophysiology is pulmonary aspiration in drowning and hypoxic ischemic injury to the brain. Pulmonary involvement may vary from mild pneumonia to severe ARDS. Mild hypothermia may be protective, but always avoid hyperthermia. A bystander CPR is the most important factor and should be initiated as soon as possible. Most of these cases of drowning should be managed immediately by the poolside for the best outcome. Because if a drowned, unconscious child comes to the ER, it's usually pretty late. Other factors that affect outcome are duration of submersion and hypothermia. Now we come to foreign bodies. Foreign bodies is another common thing seen in pediatric age group. It may include ingested foreign bodies in the nose or ear, lodged earring in the ears, and foreign bodies within a wound. Now, if you look closely on the extreme right, I showed an X-ray of a child who has swallowed a coin. Now, if you see, always with such a history, it's always better to get an X-ray, like I said, of both views, the lateral view and the AP view, to make out whether the coin is actually in the airway or the esophagus. Usually, something in the airway would cause symptoms significant and needs to be checked. Now, if you see for foreign bodies, if you see the image next to the X-ray, where the mouth is open, I don't know if any of you all can notice what the tongue depressor is pointing to. If you look closely, there is a small piece sticking out from the inner wall. That is a fish bone. Now, this kid came to us with complaints of some kind of irritation since yesterday and a history of eating fish. And coincidentally, we examined him and found this fish bone stuck here. There was no bleeding, there was nothing else, there was just mild irritation, and it just had to be plucked out with the help of forceps. Foreign bodies within the nose are another common incidents that we see in our emergencies, and simple foreign bodies that are visible can easily be handled within the emergency if the physician is skilled enough. We ourselves have removed nasal foreign bodies many times within the ER. We have also removed many ear canal foreign bodies. Always remember, if the foreign body is not visible or is too deep in, it's always wise, however experienced you are, to refer to a specialist or an ENT. Do not try to attempt deep foreign bodies on your own because you may end up causing more harm than good. On the extreme right, top hand right, is a case where we get a girl child with earring lodged in the earlobe. This is another common occurrence that we see. In certain cases, a small nick and pushing it out with the help of a local anesthetic helps. But sometimes the lobes are infected and they need antibiotics, and the child needs to be sedated, as this is a very painful thing to do. As we come to the end of our uh, talk on injuries, there are several other injuries that do take place, but I have tried to brush across most of the common injuries that we do witness in our pediatric ER. And hope if you all come across these kind of injuries, you all have a basic idea of how to manage them. And if not, always best to refer to a specialist or a tertiary care who's equipped to handle these kind of things. Thank you very much. I would also
Thank you, Dr. Behzad. Uh, there is a question for you in the chat box. Dr. Shilpa wants to know what are the basic investigations required in case of head injury.
Okay. So, see, simple, it depends on the kind of head injury. Okay. Most head injuries are simple, like the ones that they come, like they say कि बच्चा bed से गिर गया या खेलते खेलते गिर गया, and you visually look at the child, you don't find any swelling, you don't find any crepitus in the scalp area, there is no bleeding, everything looks absolutely fine. Then, using your discretion, you might not do any investigation whatsoever. But if you find some kind of a crepitus, you find some kind of a swelling with discoloration, then it would not be wrong to get an X-ray done to rule out any kind of fracture, displaced or undisplaced. And like I mentioned earlier, if the child is symptomatic, like he's drowsy or he's been vomiting ever since he's had the injury or the fall on the head, and he's having bleeding or he's having some kind of secretions coming from the nose, then in that case, you may have to consider a CT scan to rule out any kind of intracranial bleed. Because depending on the kind of intracranial bleed that I mentioned earlier, the kid might require admission in the ICU with observation and may require an urgent evacuation of the clot.
Thank you, Dr. Behzad. I think there's a question for Dr. Bharat Parmar sir also. Sir, the question is kindly guide what is the right time to collect sample for blood cultures in fever of unknown origin.
Best time will be before starting any antibiotic therapy. But since the child has already come with some antibiotic already started, then at the peak of the fever, or you can ask for antibiotic filter to be used in blood culture, but with proper precaution and a good lab, it should be collected.
Okay, thank you. Any other questions? You may unmute yourself and ask questions or even put it on the chat box. Okay. On behalf of everyone at SRCC Children's Hospital, I would like to thank all our speakers and our participants for today's masterclass. Thank you very much, and we'll be updating you soon about next month's masterclass. Thank you, everyone. Thank you to all the speakers, the participants, and Mr. Manmohan and Mr. Datta. Thank you very much.